بينهما برزخ لا يبغيان فبأي آلاء ربكما تكذبان يخرج منهما اللؤلؤ والمرجان فبأي آلاء ربكما تكذبان وله الجوار المنشآت في البحر كالأعلام فبأي آلاء ربكما تكذبان كل من عليها فان ويبقى وجه ربك ذو الجلال والإكرام فبأي آلاء ربكما تكذبان
ब्रेक की बेल बजने से पहले भूख की बेल बज जाती है जितना भी कंट्रोल करूं मैं भूख लगती जाती है
भूख लगेगी तो स्कूल में पीछे ही रहेगा और पेट भरेगा गंदम से। इसीलिए नेस्ले बुनियाद लाया नया
يسأله من في السماوات والأرض كل يوم هو في شأن فبأي آلاء ربكما تكذبان سنفرغ لكم أيها الثقلان فبأي آلاء ربكما تكذبان يا معشر الجن والإنس إن استطعتم أن تنفذوا من أقطار السماوات والأرض فانفذوا لا تنفذون إلا بسلطان فبأي آلاء ربكما تكذبان يرسل عليكما شواظ من نار ونحاس فلا تنتصران فبأي آلاء ربكما تكذبان فإذا انشقت السماء فكانت وردة كالدهان فبأي آلاء ربكما تكذبان فيومئذ لا يسأل عن ربكما تكذبان فيهما من كل فاكهة زوجان فبأي آلاء ربكما تكذبان متكئين على فرش بطائنها من استبرق وجنى الجنتين دان فبأي آلاء ربكما تكذبان فيهن قاصرات الطرف لم يطمثهن إنس قبلهم ولا جان فبأي آلاء ربكما تكذبان كأنهن الياقوت والمرجان فبأي آلاء ربكما تكذبان هل جزاء الإحسان إلا الإحسان فبأي آلاء ربكما تكذبان ومن
आज ब्रेकफास्ट में फिर कुछ स्पेशल।
हर दिन कुछ स्पेशल क्यों नहीं?
खालिस दूध से बनी पाकिस्तान नंबर 1 ब्रांडेड डेयरी क्रीम सिर्फ नेस्ले मिल्क पैक क्रीम बनाए मेरा हर ब्रेकफास्ट एक्स्ट्रा स्पेशल।
अब हर दिन खुशी से
From Nestle.
What can be made from nothing? Something remarkable, it seems. But what
دونهما جنتان فبأي آلاء ربكما تكذبان مدهامتان فبأي آلاء ربكما تكذبان فيهما عينان نضاختان فبأي آلاء ربكما تكذبان فيهما فاكهة ونخل ورمان فبأي آلاء ربكما تكذبان فيهن خيرات حسان فبأي آلاء ربكما تكذبان حور مقصورات في الخيام فبأي آلاء ربكما تكذبان لم يطمثهن إنس قبلهم ولا جان فبأي آلاء ربكما تكذبان متكئين على رفرف خضر وعبقري حسان فبأي آلاء ربكما تكذبان تبارك اسم ربك ذي الجلال والإكرام بسم الله الرحمن الرحيم الرحمن علم القرآن خلق الإنسان علمه البيان
सब वेट कर रहे हैं आपका।
आपको पता है किस चीज़ का वेट कर
الشمس والقمر بحسبان والنجم والشجر يسجدان والسماء رفعها ووضع الميزان ألا تطغوا في الميزان وأقيموا الوزن بالقسط ولا تخسروا الميزان والأرض وضعها للأنام فيها فاكهة والنخل ذات الأكمام والحب ذو العصف والريحان فبأي آلاء ربكما تكذبان خلق الإنسان من صلصال كالفخار وخلق الجان من مارج من نار فبأي آلاء ربكما تكذبان رب المشرقين ورب المغربين فبأي آلاء ربكما تكذبان مرج البحرين يلتقيان بينهما برزخ لا يبغيان فبأي آلاء ربكما تكذبان يخرج منهما اللؤلؤ والمرجان فبأي آلاء ربكما تكذبان وله الجوار المنشآت في البحر كالأعلام فبأي آلاء ربكما تكذبان كل من عليها فان ويبقى وجه ربك ذو الجلال والإكرام فبأي آلاء ربكما تكذبان يسأله من في السماوات والأرض كل
Hello. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. My name is Dr. Adam.
And I'm Dr. Alina Tariq.
We are postgraduate trainees in Neurology Department at CDA Hospital. A very good morning and assalamu alaikum to all of you.
On the behalf of our organizing committee, it gives us immense pleasure to welcome you all on the 25th International Neurology Update.
And the 7th Biennial National Headache Disorders Conference here in the heart of Islamabad at Marriott Hotel. We would like to call upon our team leader, Dr. Waleed, so he can take over the stage.
Assalamu alaikum. Thank you, Dr. Adam and Dr. Alina. On behalf of Department of Neurology of the Twin Cities, I welcome you all to this conference and a very warm welcome to the beautiful city of Islamabad. So this year's theme is Innovations in Neurology, reflects the remarkable strides our field continues to make in research, technology, and patient care. Over the next 3 days, we'll hear from the world-renowned experts who will not only share their knowledge, but also hopefully inspire us to imagine what's next. So we'll start off the session with the tilawat of the Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين.
Please rise for our national anthem. We will start our today's session with our expert panel of Professor Naila Naeem Shahbaz, Professor Wasim Akhtar, and Dr. Zareen Mughal. The moderator for today's events are Dr. Mohammad Nasrullah. Can we please have him on stage?
We start with the first session of second day. First of all, I will request Professor Mazhar Badshah, he is a patron of this conference, for his welcome address, please. Professor Mazhar Badshah, he is ex-HOD, Department of Neurology at Pakistan Institute of Medical Sciences, Islamabad.
Bismillahirrahmanirrahim. Assalamu alaikum, ladies and gentlemen. It is a kind of change from the normal norm that I'm sitting here and welcoming you all to this 25th session, update session. We are lucky that we are having it in Islamabad under the guidance of Brigadier Power, who's been always very kind, and I would welcome you all to participate. I think we are teaching the teachers. You know, most of the teachers are here and students are not there. So it's like always, students come, they always come late, but inshallah they will come. So it is going to be a 2-day session. I hope you enjoy your stay in Islamabad with our hospitality, which has been provided to you. I hope you enjoy the session. This program started some 25 years back when we thought that there should be an annual update, so what's happening around in the world in the field of neurology, and people should participate and should know what is happening. So thanks Allah, Almighty Allah, that with each year we have improved with the delivery of lectures that we upheld in the updates. The teaching has improved, the learning has improved in the departments, and we have found that after each year, the delivery of patient care service, that has improved. So that has a remarkable effect upon the patient care and learning that you provide to the students. So inshallah, this is going to be another enlightenment period of 2 days for the students and for the teachers as well, because most of us, they sit here, and the teachers and the students, they don't. But still, I think that if our knowledge is updated, we can provide better care to the patients. So I hope you enjoy your stay in Islamabad. And thank you very much for all the teachers that they come from all across the country to participate in this session. What we have inculcated recently is that our colleagues who are working in the different countries across the globe, they participate in these delivery of lectures. And then we know that what is happening in different parts of the world, and so our knowledge is updated. So it is a very great academic activity. I think all the students, all the residents should participate in it. I hope you enjoy your stay. Thank you very much.
Thank you, Professor Mazhar Badshah. As you know, this is a Zoom meeting, and people from two ends of the globe are communicating with each other. So spending no further time, I will invite the first speaker, Dr. Aruba Fahim. She is board certified in American Board of Psychiatry and Neurology, and she will be talking on immune epilepsies. Dr. Aruba Fahim, please, you can start your talk and share your slides, please.
Assalamualaikum. I'm going to go ahead and share my screen. Let's just see here. All right. Is this visible? Is everybody able to see my screen? Yes? Okay. All right, Assalamu alaikum. I am Aruba Fahim. I am a board certified neurologist with fellowship training in epilepsy. I am currently working at Salem Health in Salem, Oregon. And it is a great pleasure of mine to be talking about a rather broad and new topic, autoimmune epilepsy. So we'll get straight into that. I have no financial disclosures to report at this time. We're going to run through the objectives. Why is this so important? We'll go over the definition as well as the classification. I'll present a few cases and different kinds of clinical presentations of autoimmune epilepsy-related disorders. And then we'll talk about some diagnostic tools as well as treatment and management. And hopefully we'll have some time for questions. So why is this so important? Initially, I think about 120 years ago is when the first association between inflammation and, autoimmune disorders was found. Not necessarily epilepsy or seizures, but the association between the two. Then about 50 to 60 years later is when there were childhood epilepsies that were noted to have an autoimmune component to them. And certain medications that we normally use, such as ACTH, as well as steroids that were being used to treat autoimmune conditions, were actually being helpful in treating these childhood epilepsies. What that led to was, trying to find out why there could be certain conditions that actually have an underlying autoimmune cause. Despite the availability of so many new anti-seizure medications with various mechanisms, overall outcomes in newly diagnosed epilepsy still remains pretty poor. More than a third of the patients that experience epilepsy still don't have adequate control over their seizures. And there are several mechanisms of action for drug resistance that are still not understood. So determining the cause for the epilepsy is very important and crucial.
Excuse me, Dr. Aruba, can you share your screen, please? Because we can't see your slides.
Oh, well, let me see here. Hang on a sec. Can you see them now?
Yes, we can see.
Okay. All right. So, what I was alluding to is determining the cause for the epilepsy because of this is very important and crucial to understanding how to effectively care for our patients. So, this was acknowledged by the International League Against Epilepsy back in 2017, where they actually included immune causes as a major etiology of epilepsy-related conditions. So coming to the definition of autoimmune epilepsy, which represents about 5 to 7% of all epilepsies, it is directly the result of an immune disorder in which seizures are a core symptom of that particular disorder. There is clear evidence of CNS inflammation that has an autoimmune mediated response. And then now we have come to realize that there are a lot of adult and pediatric epilepsies that have characteristic presentations, and therefore treating them likewise will ensure better care for the patients. So before we go into the details of each of these conditions, I would like to spend a couple of minutes on the differences between acute symptomatic seizures as well as autoimmune-associated epilepsy, which are two very different entities. The task force by the International League Against Epilepsy has clarified that, we do not use time frames to distinguish the two. So very briefly, acute symptomatic seizures are those that are secondary to autoimmune encephalitis. In contrast to that, autoimmune-associated epilepsy is the direct result of an active inflammatory brain process or the long-term consequences of a prior attack, which has resulted in brain damage. The two conditions have very different characteristics, prognosis, and treatment strategies. And so when we look at this, and I don't know if this will be clear enough, but I've tried to break it down in terms of the differences between acute symptomatic seizures as well as autoimmune-associated epilepsy. But the main differences are with regards to timing. Acute, as the name suggests, is an acute active inflammatory phase of the autoimmune encephalitis, whereas autoimmune-associated epilepsy is more of a chronic condition which persists after the acute inflammation is over. So that has resolved. Pathophysiology also differs with the two because acute symptomatic seizures are a direct autoimmune attack. However, they do not result in structural damage to the CNS. It is most often associated with cell surface antibodies, and in comparison to that, autoimmune-associated epilepsy does cause permanent structural damage. There is gliosis, there is scarring, there is ongoing autoimmune inflammation, which can persist after the initial insult. And what that does is that causes an enduring predisposition to unprovoked seizures later on. This is also associated with more intracellular antigens, such as those found in GAD65 or even Rasmussen's encephalitis, which is more prevalent, obviously, in the pediatric population. Unfortunately, the response to therapy is also then different and will differ because of this pathological change, with acute symptomatic seizures having a more favorable response to immunotherapy and autoimmune-associated epilepsy not having a favorable response. The long-term
Dr. Aruba Fahim, sorry for interruption. Can you bring your slides on slideshow mode? Text will appear bigger and will be readable to people sitting on the back side.
Is this better?
Ji, thank you very much.
You're welcome. Okay. So yeah, coming back to the outcomes, the long-term outcomes. So what happens with acute symptomatic seizures is that although there may be a risk for epilepsy, it often resolves because the actual infection has resolved. Not all patients will actually go on to develop epilepsy. However, in autoimmune-associated epilepsy, there is a lifelong predisposition that exists, and they often require long-term treatment with anti-seizure medications to manage their condition. Now, there are two other entities that have come about from this, big sort of umbrella, or under this umbrella. One of those is NORSE, which is a kind of status epilepticus that is known as new onset refractory status epilepticus. It is a very sudden and prolonged sort of intractable form of status epilepticus in which no immediate cause can be found. There is no limitation to age group. And unfortunately, morbidity and mortality is very high, often resulting in chronic epilepsy. Now, a subset of that is FIRES, which is a febrile illness-related refractory seizure, and that is what the abbreviation stands for. The difference, however, is that this is, in order for this to be called FIRE, there has to be a preceding febrile illness that occurs 24 hours to 14 days before the actual status epilepticus occurs. Although the exact cause of this is still unknown, it is thought to be triggered by infections. And again, there is low limitation to age groups, although initially they were thought to be more prevalent in the pediatric population. Now, for both of these entities, they're typically very resistant to 2 or more anti-seizure medications. There is low evidence to suggest that immunotherapy is helpful for treatment. There are some new case studies that have shown that biologics like anakinra and tocilizumab, which are essentially interleukin antagonists and used for various other conditions, have proven to help prognosis in certain pediatric populations. And then, of course, there's the ketogenic diet, which has helped in certain scenarios and is recommended. So what are the common features of autoimmune epilepsy? Most of these, unlike other kinds of epilepsy, are more focal. So the seizures are more focal. They continue to occur throughout the day and may happen several times. Unlike other seizures, these are usually very short duration, but they are repetitive. So usually lasting less than a minute. They will develop, over days to weeks. Unfortunately, typical anti-seizure medications do not offer adequate control. They may be associated with certain prodromal or viral illness type flu-like symptoms, and can sometimes have an association with psychiatric changes or personality changes, resulting in paranoia, depression, hallucinations, even memory changes. And we'll talk a little bit about that once we get to the case presentations. There are specific antibody associations, which I've listed here, but due to limited time, we're not really going to go into details regarding all of them. Some of the common ones are LGI1 antibodies, which is associated with faciobrachial antistonic seizures. It's most often seen in women, associated with hyponatremia, and those kind of, it's usually a cell surface antibody. So response to therapy is actually pretty good. We have GAD65, which is an intracellular antigen and can result in something called musicogenic epilepsy, where people actually hear musical-like qualities. We are all very familiar with anti-NMDA receptor encephalitis, more common again in the female population. And then there are a few others that I listed here and won't be going into details of. So, how do we tell? What do we use and to determine whether this is a potential autoimmune epileptic or epilepsy case? And so there are some clinical predictive tools that have been found, starting with the antibody prevalence in epilepsy score that was penned down in 2016 initially. There was an updated version that came out as the APE2 score in 2020. And this is basically a guide to predict the likelihood of neuronal antibody positivity in patients that are presenting with encephalopathy or seizures. A score of greater than 4 or more has a higher specificity and sensitivity for autoimmune epilepsy. Now, there are various components to establishing the score. Some of them are weighted at 1, and the others that are a little bit higher are weighted at 2. So some of the ones that carry more weightage are things like having a viral prodrome, having CSF findings that are consistent with inflammation, having an MRI that shows medial temporal flare changes. There could also be facial dyskinesias or dystonic movements. Having an underlying malignancy would also implore a higher score. And then having a seizure that is refractory to using 2 or more seizure medications also results in a higher score. So here we have some MRI, some sequences on an MRI. There are 3 different patients, 3 different conditions. We have A and B with the axial and sagittal views. You can see that there is some bilateral medial temporal hyperintensities that you can see. This was actually a case of an anti-LG1 limbic encephalitis. This was less prominent, but you can see the hyperintensity here and a little bit of asymmetry here as well. This was a case of MA2 antibody limbic encephalitis. And then here, there is, involvement in both temporal lobes with predominance in the right side. And this was actually an anti-ANNA, which is anti-nuclear antibody, neuronal nuclear antibody, limbic encephalitis. So, you know, that's pretty characteristic, seeing these temporal, mediotemporal, sort of sclerotic changes. There was also something that is called the ACEs score, and this was developed, you know, keeping the APE score in mind. So this was something that was categorized in 2021, so it's more recent. If you look at the score, it's actually a little bit more vague. It doesn't specify exact characteristics like the APE score did, but this is used specifically for patients who have focal epilepsy of unknown origin, and is basically trying to show whether they have a higher probability of developing autoimmune epilepsy. So having a score of 2 or more has shown higher sensitivity, a decent amount of specificity as well in detecting these autoimmune causes. So the approach to workup, you know, it is imperative that you get antibody testing in the serum as well as the CSF. I know that there are paraneoplastic panels that are available for serum analysis. However, they often miss cell surface antigens, and you know, they don't test for them. So getting a lumbar puncture and obtaining CSF for testing is crucial. I personally feel that there are other things that you can pick up on the CSF as well, which are important, such as inflammatory markers, high protein counts, you know, things like that. And so I recommend testing for antibodies in both. There are also adjunct tests such as imaging, EEG, malignancy screens. Imaging, there are more advanced MRIs and PET scans where if you're in the acute phase, the acute symptomatic seizures that I was talking about, not so much in that phase, but if it becomes more subacute or more chronic, there is hypermetabolism that can be seen in those temporal lobes, and that can be a useful adjunct. Brain biopsy is rarely necessary. So I've just highlighted some of the antibodies here that are common to limbic encephalitis as well as other kinds of autoimmune epilepsies. As you can see, most of them are cell surface, but the common intracellular and more resistant, more intractable epilepsy-causing antibodies are the intracellular ones, which is MA2, LGI1, HU and G8065. And this is just a schematic showing how the attack on the neuron happens with cell surface antigens. With the intracellular antigens, there is a cytotoxic T cell response that is also at play. And because of that, it results in you know, more inflammation, more cytokine release, and thus more resistance to certain medications. So the real question is, are neuronal antibodies the gold standard? And previously this was thought to be true. However, there are some caveats. The issue is, if your antibody is positive, we ultimately assume that the patient definitively has an autoimmune diagnosis. Having said that, there are certain scenarios where there could be a low titer, such as Caspr-2, or in glycine R encephalopathy. So then what if the antibody is negative? Then we almost ultimately assume that there is no autoimmune diagnosis. And, you know, as clinicians, we all know that phenotypically you can have encephalitis with negative antibodies. And so, you know, the question then arises, what do we do? And so that is why the clinical predictive tools were developed. This is also a clinical diagnosis. So it's not just based on one test result or one gold standard test results. It's a clinical diagnosis. So you have to keep in mind the clinical picture, the severity, and then go from there. Because what ends up happening is, with false positive diagnosis, you could be exposing the patient to immunotherapy that they do not need. And at the same time, if you have a false negative, you could be delaying treatment that could have saved or helped them earlier. So I'd like to talk a little bit about this case that I saw when I was a second-year resident, a neurology resident back in Arizona. So I had this 19-year-old young woman, graduate student, who came in with no significant past medical history. She was presenting with sudden tonic-clonic seizures, behavioral changes, confusion, no significant illness, no travel outside the country. She did go on a hiking trip with her family within the state, but, nothing out of the ordinary. Physical exam, she was mildly tachycardic, a little dysarthric, wasn't really corroborating her history, could not really follow commands. There was this very stiff posture that she had in all four limbs. Her reflexes were normal and her gait was ataxic. Initial labs were within normal limits. CSF was pending. Serum antibody panel was negative. MRI brain with and without contrast was also within normal limits. And initial EEG showed diffuse slowing, but no epileptiform discharges. So she continued to wax and wane for a week. No major changes in cognition or behaviors. But she was beginning to show different kinds of seizures. And some of those comprised of staring spells. She also had tonic-clonic events with drooling and grinding of her teeth. And then there was a third type of seizure that she was having where she was having this lip-smacking kind of movement lasting a few seconds. By now, her CSF had returned positive for elevated protein, but the antibodies were still pending. However, what we noticed was her EEG findings had changed. And so in addition to the diffused background slowing that we were seeing, we were also seeing something called delta brush pattern, which is a slow wave with, a frequency of about 0.5 hertz to 1.5 hertz. And this is, in some pediatric populations, it's normal or considered normal, but in the adult population, it's actually now called an extreme delta brush, and is synonymous with a lot of autoimmune conditions, especially NMDA receptor encephalitis. So her CT chest, abdomen, pelvis was negative for any masses. Her CSF panel came back positive for NMDA. We had already, by the way, been treating her with, first we did steroids, high-dose IV steroids. We had then done IVIG. And then finally, treatment was started with rituximab, obviously after we counseled the family, went over, the implications and all of that. It did work beautifully for the patient. 6 months later, she walked into clinic as a follow-up, was very thankful for helping her get through this, and denied having any further seizures or disabling after effects. So, which brings me to who is at risk. Now, although the initial cause or the cause generally is unclear, this is a significant population. This is about 5 to 35% of patients with new onset seizures may have an autoimmune cause. And so it is prudent to say that if there is an autoimmune, like another autoimmune condition that the patient has, for instance, Hashimoto's, Sjogren's, hypothyroidism, SLE, these are some common ones that have been found to have a link with autoimmune epilepsy, and also a family history of autoimmune epilepsy of some kind, then this is something to note. A red flag which should jump at us is a sudden and severe onset of seizures, as that might be the first indicator of an autoimmune etiology. So treatment, I've always said this, I will continue to say this, if a patient is hospitalized, do not wait to treat. If you feel like they are fulfilling some of the criteria, but not all of them, if you suspect that no other cause has been found, just go ahead and treat them. Start the steroids, start the IVIG, whatever the case may be. Waiting for the antibodies to come back is just delaying care and is not helpful in overall management. Escalation of therapy will depend on clinical severity and how the patient has responded. There have been cases where we have had to induce like a medically induced coma with propofol or Versed or midazolam, based on the clinical severity of the patient. And remember that maintenance of that immunosuppression, which is technically second-line therapy, is crucial to long-term prognosis. So first thing that we use are corticosteroids, which we would use a pulse of methylprednisone over 3 to 7 days, followed by high-dose oral prednisone. It's usually preferred in LGI1 and paraneoplastic syndromes. And is something that we should exercise caution with in patients who have other comorbid conditions, such as diabetes, hypertension, and psychosis. The next line is intravenous immunoglobulins. Dose is 2 grams per kilogram over 2 to 5 days. They may require a repeat dose in 4 weeks. It's often used in conjunction with steroids, like we did with my patient that had NMDA, and it is specifically helpful for surface antibody-related conditions like NMDA. However, there is a concern for clot potential. And then we come to plasma exchange, which is a little bit more challenging and hard to come by. I think, just generally it's a little bit more challenging because of the amount of sessions that are required. It's usually preferred for demyelinating syndromes. And there are some more risks associated with it with regards to volume shifts, bleeding risks. Patients can exhibit more agitation, psychosis, and of course you need a central line to be administering the plasma exchange. So, if it's been 2 to 4 weeks with the initial therapy and you haven't seen any major improvement, you go to your second line of defense. And your second line of defense is using hardcore immunotherapy, which includes rituximab, cyclophosphamide, and some biologics. Now, rituximab is better tolerated. It is less helpful for T-cell mediated. So, the intracellular antigens that we were talking about, it's a little less helpful for that. If there's an insufficient clinical response, you may need to track the CD19 count in 4 to 6 weeks to see if they're undetectable. If that doesn't work, then there's obviously cyclophosphamide, but the problem with that is it is more toxic, can cause infertility, which is why in certain populations it is more risky to use. And you have to check your CBC every 2 to 3 weeks to assess for diminishing white cell count, thereby adjusting the doses. Now, some of these new biologics that have come out, they've been tested more so in the pediatric population, but they have proven to be helpful. So this is just a flow chart of what you should be doing if you are suspecting autoimmune epilepsy. So if there is a new onset seizure where you don't feel like there is a clear etiology, they are resistant to multiple seizure medications, they're exhibiting CSF findings that are indicative of inflammation, or they have MRI findings that are indicative of inflammation, and they have an antibody as well. Go ahead and do your immunotherapy trial. Start with the steroids, do the IVIG, do the Plex. If there's improvement and there's greater than 50% reduction in seizure frequency, I think it's fair to say that that is a diagnosis of autoimmune epilepsy, and you can plan to do chronic immunosuppression, either with the IVIG or the steroids, and maybe consider other suppressants later on in the future. If you fail and there is no objective improvement, then please go to your second line of defense and continue the cycle.
Dr. Aruba Fahim, you have 2 more minutes.
Yes, I'm wrapping up. So what to avoid, don't wait for antibodies to return. Like I said before, don't track the titers. That isn't helping anything. Don't repeat the same modality for treatment if failure has already been noted. Move on. Use more objective markers like EEG, imaging, seizure diaries, and treat the seizures, don't just let them be. What you should be noting is the type of antibody, because that's going to help you specify what mode or what mechanism of action to use for your immunotherapy. If a person has a history of relapses or a history of cancer, that is also helpful in determining what this diagnosis may be or what this is stemming from. Severity of clinical presentation also determines how aggressive we need to be with treating the patient. Obviously, patient preference matters as well, with regards to where they can get the treatment, whether it's easy for them to come every month for monthly tests. All of those things need to be considered. And of course, it is also very important to consider other chronic conditions along with it. And then de-escalating your anti-seizure medications, even if they were started at some point, they can interact, there can be other side effects. So please de-escalate that if you are not noticing an improvement. So these are my references. And I have maybe less than a minute to take some questions. Thank you very much.
Thank you, Dr. Aruba Fahim, for very good talk on this important subject. If there are any questions, house is open. Professor Mujibur Rahman Abid Bhatt.
Yeah, Assalamu alaikum, Dr. Ruba. Sorry, I just joined just now. I have been managing NMDA receptor antibody encephalitis, and the patients had been responding to solumedrol, methylprednisolone, but I have found that even after giving IVIG, the day I started with the rituximab, so I generally start about 500 milligrams once a week for 4 weeks. I actually follow this one. And then after every 6 months, obviously, you give 1 gram. The response to rituximab was excellent. So in your experience, or if we cruise through the literature, does the literature say that if the patient responds to the methylprednisolone is not that optimal, rather than waiting for the IVIGs or the plasmapheresis, we just go to the biologicals?
Yes, yes, I would agree. And personally, like in fact, this patient that I had talked about in my presentation, that is what happened. Initially we had started her on the steroids, we had done the IVIG. Just because she was, a 19-year-old girl, there were some reservations as to whether we should start rituximab, because that would entail long-term management. But there was a beautiful response, and I completely agree. I have seen that there, specifically with rituximab and NMDA, they respond very well. And I think there's sufficient literature to suggest that too. So based on my experience and your experience, this is what I would recommend. Obviously, there are various factors, finances and things like that, which we have to consider. But yes, it is preferred.
Now, coming to the head-to-head, patients with an immune epilepsy or immunologically related epilepsies, or a patient with a primary idiopathic epilepsies, I think that in the interictal phase, the patient's presentation, the manifestations are quite different actually. In an idiopathic epilepsy, the person becomes absolutely normal. He's a fully GCS 15/15, MMSC maybe 29, 28/30. But in patients who have a background of immunological disorder going on, causing the epilepsies, in the interictal phase, we do find many things actually, which pushes us to further investigate and I think to treat accordingly.
Absolutely.
Thank you.
Thank you very much, Dr. Urba Fahim, for making us wiser on this important subject. Now we move to the second talk of the session. Professor Amir Araim, he is epileptologist with special focus in refractory epilepsies. He is going to talk on refractory status. Dr. Amir Araim, please. You can share your slides and start your presentation.
Yeah, can you see my slide?
Yes, we can see.
Good morning. Thank you for inviting me. It's nice of my mentor, Dr. Aslan Ahmed, to invite me. I'm going to talk about status epilepticus and refractory status epilepticus. My disclosure is that I'll be talking about some off-label use of medication and some treatment for the treatment of status epilepticus. So the overview is the status epilepticus definition. We'll talk about convulsive status epilepticus, and then pathophysiology, and then refractory and super-refractory status epilepticus. This is just a schema of different status epilepticus types. So status epilepticus is clinically diagnosed if a generalized tonic-clonic seizure continues more than 5 minutes. And then we'll talk about the first-line therapy. And then established status epilepticus is when the person arrives in the ED, and then we typically start the second medication. And if the seizure doesn't respond to the first and the second therapy, then this is considered to be a refractory status epilepticus. And then typically we use the anesthetics to put them under general anesthesia. And after 24 hours, we typically lighten the anesthesia and let the patient wake up. And if the seizures still continue, then it's considered to be super refractory status epilepticus. And this schema basically tells you the same thing. Prolonged super refractory status epilepticus is something that lasts more than 7 days with ongoing anesthetics. Or in refractory status epilepticus, if they continue for at least 7 days without the use of anesthetics, that's also included in this. So ILE says that status epilepticus is the condition resulting either from the failure of the mechanism responsible for seizure termination or from the initiation of mechanism that would lead to abnormally prolonged seizure, typically time point 1. And when it passes beyond time 2, then it usually causes neuronal damage, neuronal injury, and alteration of neuronal networks. So what they are saying is that status epilepticus, time 1 is when we declare it is status epilepticus if it is more than 5 minutes, or in case of all other seizure types, whether non-convulsive status or focal status, it is 10 minutes or more. After 30 minutes of convulsive status epilepticus, we typically see neuronal damage and neuronal death. And for other types, we start seeing the neuronal damage after 60 minutes. So refractory status epilepticus is the recurrent seizure activity despite 2 appropriately selected and dosed anti-seizure medications, including a benzodiazepine. Superrefractory status epilepticus is that seizure continues or recurs after 24 hours or more after the initiation of the anesthetics. So these are the distinctions. Epidemiology of status epilepticus, almost all seizure status epilepticus in adults, the incidence is about 36 per 100,000 per year, and non-convulsive status epilepticus is about 12 per 100,000 per year. And 50% of the patients who present with status epilepticus have their first presentation of epileptic event as status. And refractory status epilepticus, the incidence is about 7.2 per 100,000, or roughly about a third of the status epilepticus. And superrefractory status epilepticus is 1.2 per 100,000 per year, roughly about a 20th of the status epilepticus. Patients develop that. And here is the graph showing increasing incidence of status epilepticus in elderly. And you can see here clinically convulsive status epilepticus or status epilepticus with prominent motor signs, and then non-convulsive status epilepticus. And you can see that there is a gradient, and with higher age, you tend to see more non-convulsive status epilepticus or status epilepticus with prominent motor activity. The etiology of status epilepticus, most common is hypoxic brain injury, cerebral vascular accident, tumors, metabolic condition. In lower income countries, typically the infectious disease is the most common cause for status epilepticus, and cerebrovascular and degenerative cerebral etiologies prevail in the higher income countries, and metabolic causes or non-adherence to medication occur in both regions. NORS is the new onset refractory status epilepticus in persons without any pre-existing active epilepsy and without a clear acute or active structural or behavioral, structural or metabolic or toxic cause. FIRES, which is febrile infection related epilepsy syndrome, is a subsidiary or subcategory of NORS. FIRES require that you have to have a febrile illness 24 hours or 2 weeks, up to 2 weeks before the onset of refractory status epilepticus. It can happen at any age. Most common cause is autoimmune encephalitis. Infections are the most common cause in pediatric NORS. Once the infection cause has been ruled out, it's always good to start IV methylprednisolone for 5 days, followed by IV immunoglobulin or plasma exchange to treat that, because it can be there can be serious consequences from NORS. Looking at the pathophysiology of convulsive status epilepticus, what we say the principle is the time is brain. The earlier you treat it, status epilepticus, you have a better outcome. So time is brain, and this study came from Kapoor and McDonald back in 1997. They looked at mouse brain, a person who had a mouse which has had seizure for 10 minutes, and effective dose of diazepam to stop the seizure was 4.2 milligram per kilogram. And the seizure that lasted more than 45 minutes, you can see the effective dose to treat that with diazepam is 10 times more than if it was treated earlier. So the longer the duration of status epilepticus, the more difficult is it to treat. The GABA receptor pharmacology, all the benzodiazepines attached to GABA receptor, they have a different site than for barbiturates. Here with status epilepticus, we see that the ongoing status epilepticus shows there's a dropout of GABA receptors. And here we have the control, and on the right is the status epilepticus, and you can see there is dropout of GABA receptors compared to the control. On the other hand, there is more presentation of NMDA receptors, excitatory receptors. And here you have control, and there you have status epilepticus. With passage of time, continuing the status epilepticus, there is upregulation of NMDA receptors. So there is tilt towards excitation. So that is the reason for self-perpetuation, perpetual status epilepticus. This cartoon shows the same thing. Basically, at baseline, you have more GABA receptors along with NMDA receptors, but as after the seizure is prolonged, you can see there is dropout of the green, which are GABA receptors, and there is upregulation or more representation of glutamate receptors. So the key point here is that the longer a seizure lasts or status epilepticus lasts, the GABAergic medication may not be effective. So later phase where you have super refractory status epilepticus, because there is so much glutamate receptors available, the medication and that would be effective would be anti-glutamate or anti-NMDA receptor medication or anti-kainate receptor medication. Example would be felbamate, which is anti-NMDA, and kainate receptor antagonist is topiramate. And we have another medicine called perampanel, which is an AMPA antagonist. So in those refractory cases, when we have no other medication that are effective, especially GABAergic medications, then we should use anti-glutamate medications. All right, so this is the summary. Synaptic GABA receptors are internalized during status epilepticus. NMDA receptors, surface expression increasing, contributing to increased excitatory drive. So translation to clinical practice, there was this study between lorazepam and diazepam and placebo for status adults with prolonged or recurrent generalized tonic-clonic seizures given out of the hospital treatment of IV lorazepam, IV diazepam, or placebo. And the primary outcome was seizure termination at arrival to ED and respiratory status decline requiring assisted ventilation, more common in placebo group. So what we found that lorazepam patient had a better outcome. The status epilepticus terminated more in lorazepam group compared to diazepam. And ongoing status epilepticus was less in the lorazepam group compared to the diazepam. This showed that lorazepam IV is better than the diazepam for convulsive status epilepticus. Then there was another Rampart trial which compared intramuscular midazolam versus IV lorazepam therapy for pre-hospital status epilepticus. And in the intramuscular midazolam group, 73% had stopped seizure by arrival in the ED compared to 63% in IV lorazepam group. So IM midazolam did much better. And median time to active treatment was 1.2 minutes, which is less than the IV lorazepam group. That was about 4.8 minutes. And in intramuscular midazolam group, significant increase in percentage of patients being discharged from the ED, while we did not see that with IV lorazepam. So we have class 1 evidence for lorazepam and midazolam. At this point, you can see that other medications, phenytoin, phenobarbital, valproic acid, levetiracetam, we don't have class 1 evidence. So it's a class 2 evidence so far. So let's see, the patient comes to the ED. At this time, this status is ongoing, and they have gotten the benzodiazepine, so they will get the second-line therapy. Previously, in our status epilepticus protocol, we used to use first phenytoin first, but now levetiracetam IV and lacosamide have superseded phenytoin or valproic acid because of ease of use and also better tolerability compared to phospheniton. So IV lorazepam, IV levetiracetam, Keppra, would be the best choice for as a second-line therapy, or we use lacosamide. Okay, so if given that and still the seizures are not controlled, then it's called refractory status. So there was a trial comparing phenytoin, valproic acid, and levetiracetam. And these were the doses. Levetiracetam dose was 60 milligram per kilogram, maximum 4,500. And the primary outcome was seizure cessation at 20 minutes. And in this double-blind trial, they noticed that in children, adults, and older adults, they all responded to all three medications with a response rate of 50% of patients. So in elderly patients, however, you see that Depakote was slightly better than the other two, but it was not statistically significant. Now you have given the second medication and the seizure is still continuing. This is refractory status epilepticus. At this point, patient is intubated, continuous EEG is initiated, and then third line therapy started, midazolam, propofol, or pentobarbital. So midazolam is given as a bolus of 0.2 milligram per kilogram. Maintenance is 0.1 to 0.4. Usually titrated to seizure suppression, doesn't need to be on burst suppression pattern on the EEG. Has a rapid offset, but also has tachyphylaxis, and cardiovascular suppression can occur. On the other hand, propofol is bolus given, and then the maintenance, titrate to seizure suppression, again on the EEG. Hypotension can happen. Limit at our center, we usually don't give propofol more than 48 hours due to the risk of propofol infusion syndrome, which basically manifests as severe metabolic acidosis, rhabdomyolysis, renal failure, and cardiovascular collapse. And then pentobarbital, if midazolam and propofol fail, we usually switch to pentobarbital, or if the 24 hours of midazolam and propofol has been done and the seizure still continues, meaning super refractory status epilepticus, then we can use pentobarbital, which is also given as a bolus. It also enhances GABA receptor action. It has a longer half-life, many drug interactions, and the complication is that it can have significant drug interactions and have several other complications like cardiovascular depression, paralytic ileus, and decreased clearance of bronchial secretion. So when you have refractory clinical convulsive status epilepticus, often use midazolam or propofol as the first line agent. Titrate to seizure suppression on EEG, not necessarily burst suppression. Wean the anesthetics after 24 hours, and that's what we do typically. And pentobarb used if midazolam or propofol fail. Just remember, when you're titrating pentobarb off, often we see generalized periodic discharges. This is a transient pattern, so don't get worried about it. Back off and let the patient wake up, even though the EEG may look very vicious, but usually those are interictal. That's a transient phase, so don't need to put them back on the general anesthesia. Here we have the refractory convulsive status epilepticus comparison of IV anesthetic agents. All three of them, midazolam, propofol, and pentobarbital. So mortality-wise, there's no significant difference. Hypotension was more commonly seen with pentobarbital and propofol, and withdrawal seizures were more common with midazolam, and breakthrough seizures were more common with midazolam. Here we have all three together, as well as ketamine, which is an NMDA antagonist. So it is now being used more popularly for refractory status, super refractory status epilepticus. Half-life is short, like propofol and midazolam, and it can cause some issues. It is given as a bolus and then maintained. So seizure continues after anesthesia is withdrawn, or despite being on anesthetics, they may continue to have seizures. At this point, it is called super refractory status epilepticus. We don't have a set recipe for treatment at this point. So it's more of a kitchen sink approach. Ketamine has been used quite a bit. So you bolus it and then maintenance up to 5 milligram per kilogram per hour. And it does not have significant cardiovascular depression, may increase ICP. Theoretically, there is a risk of neurotoxicity because of anti-glutamate effect based on some animal model data. Retrospective cases, 60 cases suggested that early use of ketamine at a maintenance dose more than 0.9 milligram per kilogram per hour may have a greater utility. At this point, as I said, there is no cookie cutter approach. There is no set pattern. We have used different medications at this point. Ketogenic diet has been used in children. 7 out of 9 patients with fires had resolution of status epilepticus within 2 to 4 days following onset of ketonuria. And adults, 10 patients, 7 with encephalitis, median status epilepticus duration of 21 days, and status epilepticus ceased in patients with a median 3 day of treatment. Hypothermia has been used. There are case reports and one small case series suggest a benefit of cooling to 33 to 34 degrees centigrade. It may be neuroprotective, typically used in association with IV anesthetic treatment with goal of burst suppression, may cause coagulopathies, bowel ischemia, and immune suppression. Hypoxic ischemic encephalopathy resulting in status epilepticus previously was considered to portend a poor prognosis, but there are some reports where a minority of these patients have a good outcome. So the earlier status epilepticus and myoclonic appears in these patients post-anoxic, and later the background returns, the worse it will be for the patient. Seizure EEG semiology also contributes. High voltage, diffuse, and identically looking epileptiform discharges like generalized periodic discharges on a suppressed background suggests a malignant form. On the other hand, lower voltage spikes around the midline superimposed on a recognizable reactive background suggests potentially favorable form. Return to brainstem reflexes, presence of N20 in median nerve SSCP, lack of markedly elevated serum NSE, neuron-specific enolase, and lack of diffusion-weighted MRI changes indicate the possibility of recovery upon treatment. So in those patients, it's better to give them conservative or supportive treatment. Neurosurgery has been done, like surgical technique has been used in some cases of suprarefractory status epilepticus. There are reports of hemispherectomy, multiple subpial transactions, corpus callosotomy. We have done RNS in acute cases. However, these are anecdotal reports of having good outcome, but most of the time it may not change the course, but still should be considered. I wanted to share a case of 3-year-old boy with 8-month history of abnormal movements consisting of right arm extension, downward eye deviation, turning blue, and drooling. Had been told that events are likely behavioral. It presented with focal status epilepticus, tried multiple medications, diazepam, levetiracetam, oxcarbazepine, topiramate, then pentobarb coma for 48 hours, then zonisamide and valproate were all ineffective. MRI showed a lesion in the left frontal area, as you can see, circled with a red circle. This was hyper on PET scan. In cases where person has seizures, repeated status epilepticus, but there are no changes seen on the EEG, it is good to get a PET scan. That will show you that there is hyper metabolic sign in those patients, while EEG may not be effective, it may not show any ictal discharges. So keep that in mind, like in this case where you can see that in the circle left frontal lesion was hypermetabolic because it's on fire and was having ictal discharges repeatedly. So they took him to the OR, day 17 for
Excuse me, sir,
left.
you have 2 more minutes. We're running short of time.
Meninectomy with intraoperative ECOG, sure. It was focal cortical dysplasia, and patient has been seizure-free since surgery 6 years ago and is off anti-seizure medications. Other things that have been used are IVIG, Plex, IV steroid, early in the case of suprarefractory status epilepticus. If you suspect autoimmune etiology, send serum, but most importantly, send CSF for autoimmune panel. Inhaled anesthetics, there are small retrospective case series published. Vagus nerve stimulation has been used, responsive neurostimulation has been used, ECT, transcranial magnetic stimulation, all have been used in suprarefractory status epilepticus. The prognosis, retrospective review of 63 patients whose status epilepticus persisted despite at least a week of anesthetic-induced coma. 14 patients, 22% had good outcome. And some of these patients won status up to 79 days. So normal initial head CT was a predictor for good outcome. Most common etiologies in these cases were CNS inflammation, epilepsy, and post-neurosurgery. So the summary is that treat status epilepticus early. Time is brain. EEG may be highly specific for non-convulsive status, but there are many cases where it is not definitive. If you don't see anything on the EEG and you're suspecting seizures, get a PET scan. Timing of treatment likely remains important in refractory status epilepticus and super-refractory status epilepticus. Identify and treat the presumed underlying etiology whenever possible. Immune modulatory therapy early if you think autoimmune etiology is there. I'll stop here and answer any questions.
We can take one question. जी, Professor Arsalan साहब.
जी.
Please mic दें इन्हें.
Thank you, Amir. Fascinating talk.
You're welcome.
I frequently bother Dr. Amir when we get stuck with super refractory status. And there was one time when we were just stuck, nothing was working. So he suggested the perampanel loading dose. And fortunately, we have perampanel available. So my question is now our pediatric neurologist is using the same loading dose to about the super refractory status. Is there any good data on the same?
Not a good data as such, not a large case series, but there are anecdotal reports that perampanel, which is AMPA blocker, at dose of 20 to 26 milligrams is very effective in super refractory status epilepticus. Yeah.
Thank you, Professor Amir Saab, for making
us,
for updates on this very important topic. Thank you very much.
Sure. Thank you for inviting me.
Now we talk to the last talk of this session. Dr. Burhan Chaudhary, he is expert and special interest in multiple sclerosis. He is going to talk to us on new treatment options in multiple sclerosis. Dr. Burhan Chaudhary, please.
Can you hear me?
Yes, we can hear you. You can put your slides on slideshow. Thank you.
Okay, right. Thank you. Thank you. I don't see. Can you see my video? I'm sorry. Right. Okay. Assalamu alaikum, everyone. My name is Burhan Chaudhary. Thank you to the Pakistan Neurology community for inviting me. I really appreciate it. I'll be sharing going into anti-CD20 therapies that are in MS, specifically the one that is available in Pakistan, which is ocrelizumab, also available by the name Ocrevus. My disclosure, which is pertinent to this particular presentation, is that this session has been sponsored by Roche, Pakistan. And I do appreciate, I'm sorry, I do apologize for my tardiness. I just got off a long flight. I was actually at a MS meeting in Barcelona where some of these learnings I'm sharing with you as well. So as Dr. Arai was mentioning, time is brain. I think this can be applied to every neurological disease, really. When the first time this term was coined, it was specifically to stroke. When we were treating acute stroke, the whole mantra was time is brain, time is brain. So that's why we need to treat early with these inhibitors. But this statement really applies to every other neurological disease. Why does it apply to MS? I mean, we are all aware that MS is a spectrum where, certain phenotypes of MS are inflammatory in nature, and then certain phenotypes of MS are neurodegenerative in nature. And both of these phases really are present on a spectrum where the inflammatory parts come early and the degenerative part comes later. So now the thought process is, the approach is that in the inflammatory phase, if we treat patients early with high efficacy therapies, the patient's outcomes will be much better, which has been shown over the last few years with this, some of the data I will share. Now, what I just spoke about, treating early, that is really our window of our opportunity to treat these patients with therapy that will have a significant impact on inflammation, and then will translate to prevention of disability. We have clear data that shows that if we treat MS in a timely fashion, if we can inhibit inflammation in a substantial way, that will lead to better outcomes in terms of clinical relapses, imaging changes, and then progression as well. And this is where the approach to MS has really revolutionized, because prior to this, the approach was escalation therapy, as opposed to the quote-unquote induction therapy that we have with some of the therapeutics available to us. Now, this is what I mentioned briefly, is, the escalation therapy versus a quote-unquote induction therapy. So historically, our approach to MS used to be is that, all right, okay, once the patient has been diagnosed, maybe we can wait for some time before we see some more disease activity in terms of relapses or imaging changes. Then over time, as more and more drugs were approved for MS, that approach did change, but not significantly. Still, the approach was that we are going to treat these patients with, like, platform therapies, the interferons, the glutamate acetates. And then if the patient breaks through on that, then we're going to go to the highly active. Which was another tier of a lot of these oral therapies, specifically S1P receptor modulators and fumarates. We will go to that. If there's a disease breakthrough on that, then we will go on to the really highly efficacy therapies, where the anti-CD20s come in, specifically ocrelizumab, and then there are others as well. There are two studies going on right now, which are referred to as Treat MS, which is led by the group in Hopkins, and the other one is Deliver MS, of which I am a part as well, which is led by the Cleveland Clinic group. And both of these trials are looking at head-to-head data of where patients will be treated with the platform therapies or the moderate efficacy therapies. And then the other group will be treated with these high efficacy DMTs, of which ocrelizumab is a part as well. It'll be really interesting to see what that data shows. But and these two are the first of their kind where there is a direct comparison to each other. Most of the literature data we have has really been gathered out of the phase 3 trials for these approved therapies, and looking at what the rates are. And then if you look at the towards the right side of this slide, the pyramid has been inverted, where we want to treat patients with these high efficacy therapies, which ocrelizumab has really played a significant part, where we treat these patients early so that there is no evidence of disease activity. This is really, speaking to the same thing, where you can see that the the interval ratio for these high efficacy at the therapies up top is much better than the orals, which are mid-tier efficacy, and the platform therapies. Now, again, this is really going at the same point, is that these high efficacy therapies, you can see that the two lines over here, the one in red is the high efficacy, the one in gray are the lower efficacy therapies. And you can see in the follow-up years, by about year two, there is clear separation between the two in terms of confirmed disability progression. So this data set does show that if we do start patients early on high efficacy DMTs, we can really alter the course of the patient's clinical course. This speaks to the same phenomenon where we have patients with the top green line or black line, I'm sorry, being the low efficacy platform therapies, and the yellow line being the high efficacy therapies. And you can again see that the separation occurs, pretty early on the disease, and it does keep going on. And what this is, the conversion of patients from relapsing remitting MS to secondary progressive MS, from the inflammatory phase of the disease to the degenerative phase of the disease, where a lot of disability is accumulated. And you can see over here with the high efficacy therapies, the rate of secondary progressive MS is significantly lower. And that has clearly been shown. If you look at registries out of Europe in the early 2000s, almost half of patients with relapsing remitting MS used to progress to secondary progressive MS. That number has come down significantly in some registries as low as 26%. Typically that ranges to 26 to 30%. But still, that drop is significant in 25 years, where these high efficacy therapies have really made a significant impact on these patients. Wanted to share with you over here. So these high efficacy therapies over here are natalizumab, alemtuzumab, mitoxantrone, and the anti-CD20s. Now, of these, the anti-CD20s are available to you. Both ocrelizumab is available to you, rituximab is available to you as well. And then mitoxantrone is available to you as well. And I am aware that Professor Arsalan and his team at Shifa, they do have a good cohort where they treated patients with the mitoxantrone with really good outcomes. And you can see that I have highlighted over here the analyzed relapse rate of this group. So you can see that the early treatment group, that rate is 2.36, and the late treatment group is 1.93. So there is a significant difference over there. There is also a difference in the EDSS scores as well. So just again, highlighting the fact that, high efficacy therapy early on does make a difference. Now, this is a comparison from the OPERA trial. These trials were phase 3 trials in which ocrelizumab or Ocrevus was directly compared to interferon. And they looked at the rates of NIDA, and NIDA signifies no evidence of disease activity, which is basically which entails analyzed relapse rate, GAD-enhancing lesions on the MRI within the CNS, and then confirmed disability progression. Now, if you see the comparison between the two, the rate of NIDA in the interferon group was about 44%. In the ocrelizumab group, it was rounding off to 73%. So significant difference, almost 30% of patients more achieved NIDA. Now, that's almost 1/3 patients more achieving NIDA who were on the ocrelizumab arm, and that is pretty significant. And when this data came out initially back in 2016, this was really, really impressive. And then the same parameter in terms of outcomes for NIDA for both interferon and ocrelizumab. This is from the OPERA study itself, which we just went over, and the open label extension study, which was up to 9 years. So the trial itself was 3 years, and then these patients in the open label extension were followed up to 9 years. And these rates did hold up for a longer period of time. As you can see, that NIDA for the interferon patients was 30%, and for the ocrelizumab arm, it was 48%. So, you know, close to almost double the patients were achieving NIDA in the ocrelizumab arm. So again, you know, these results were very impressive at the time. Now we'll be going over some progression data from that study. Again, we have 2 arms, the black arm up top being interferon group and the green one being ocrelizumab. Now you can see over here in the red highlighted box over here is that there is separation pretty early on. So around month 24 to 30 is when you start seeing clear separation. And this is a separation in terms of confirmed disability progression at 24 weeks or 6 months. So clearly, you know, patients who were receiving ocrelizumab, you know, their disability accumulation over time was less compared to the interferon group. And you will see is that this difference that we see initially really maximized by the time of week 96, and it keeps on continuing at the same rate pretty much until the end of year 9. So over 9 years, these patients were on ocrelizumab, the disability accumulation was much less, which is really significant for these patients because it may be the difference for these patients from either using a cane or ending up in a wheelchair. So again, very impressive results. Now this is took data from the OPERA study, which was in relapsing remitting MS, which we just discussed. There was a third arm in this study as well, where there was a crossover. So patients who were on the interferon arm, once they completed the clinical trial, in the open label extension, there was an option to go onto ocrelizumab. And this data set shows that patients who were on ocrelizumab before the patient arm that was on interferon and then switched over to ocra, that the rate of disability progression was higher in the patients who had started on ocrelizumab later. So that point indicates yet again is that if you treat patients early with high efficacy DMTs, you know, it does make a significant impact on disability progression. All right, okay, so this was the ensemble trial where ocrelizumab was given to DMT naive patients, so patients who had not been exposed to a disease modifying therapy. And also, they were early in their MS as well. The EDSS was 0 to 3.5, and they must have had you know, some MRI activity as well. So really, again, you know, patients who were early on their disease, DMT naive, who were given OCRA, their disease trajectory compared to patients who had not been on OCRA was different again. So again, really emphasizing the fact that ocrelizumab does have a significant impact on progression. We did talk about that, and then I just wanted to briefly touch upon this. Now, there are 2 main mechanisms which drive progression. There is relapse associated worsening, where patients either have a clinical relapse or they have activity on imaging. And that is what leads to progression. So there is a direct correlate between early inflammation and then worsening progression later on. Then we have PIRA, which is progression independent of relapse activity, meaning that there is no inflammatory activity going on, there are no clinical relapses, there are no imaging activity, but still the patients slowly over time tend to accumulate the disability. So this shows that degenerative process still keeps going on despite of no relapse or imaging activity. So these are the two main processes which really drive it. And ocrelizumab, it really, when we come to that, so since it is inhibiting inflammation in these patients, relapse associated worsening is completely taken out, where ocrelizumab has very, very impressive data. And I just wanted to get a really quick time check because I wanted to talk about something else really, really quickly. Do I have a few minutes?
You have 2 more minutes.
Okay, all right. So this is, just again, that the main takeaway message is that ocrelizumab does not only have an effect on inflammation, but on progression as well. Now, there is something else I wanted to quickly touch on, which is another work that I'm heavily involved in, is CAR T cell therapy. Now, can you see my slide?
Yes, we can see.
Okay, so this is something that has come up in the last 2 years, really CAR T cell therapy in autoimmune diseases. Now, my colleagues may know that these CAR T cells are approved for hematological malignancies, lymphomas, myelomas, and they have made a significant impact on those patients. And what CAR T cells basically are manufactured or engineered T cells which go after pathogenic B cells. So this CAR T cell that I'm specifically working on is an autologous CD19 CAR T, meaning that these CAR T cells, they go after CD19 positive B cells. And what happens is that we collect the plasma from patients where we take their T cells, and the T cells are manufactured to these CAR T cells. They are basically, transformed into these cells that are going to go after B cells. Once the manufacturing of CAR T cells is done, they are given back to the patients as an infusion. And once these CAR T cells are given to the patient, they expand within the patient and then go after these B cells. Now, the excitement around CAR T is that we're going to be achieving a quote-unquote immune reset, meaning that once patients get these CAR T cells, there will be immediate B cell aplasia. The B cells will be gone completely, and then the B cells will repopulate typically around 3 months. The median time we've seen in these autoimmune trials is about 3 months when these B cells come back. And when they come back, what's really interesting is that majority of these B cells are naive B cells. And the memory B cells, most of them are gone, which is why we feel that we are achieving this immune reset with these B cells that are naive and hopefully will not be pathogenic. And that's why that we have a lot of studies going on across multiple rheumatological indications, specifically lupus, Sjogren's, myositis, and rheumatoid arthritis. And then the same approach was applied to neurology as well, where we are treating patients with multiple sclerosis, myasthenia, CIDP, Lambert-Eaton syndrome, stiff person's syndrome, and there were previous talks about epilepsy associated to autoimmune encephalitis. There has been a case report published in autoimmune encephalitis, and another one will be coming out in NMDAR encephalitis as well. And there's a case published in MOGAD, and then a case series in NMO as well. And all of the results have been very promising so far. So there's a lot of excitement around the modality of CAR T. And what I was mentioning was that how these CAR T cells, once they are given to the patient, they really go after B cells. And
Dr. Burhan, can you please wind up?
Okay, all right, okay, thank you. So I just want to quickly say is that two things really separate CAR T cells. One is that they have deep tissue penetration, so they get into lymph nodes, skin, adipose, multiple organs really quickly and with really good penetration, and CNS. They get into the CNS at very, very high levels, and so the hope is that they're really going to go after these CNS resident B cells and the pathogenic B cells, which we believe are responsible. And I'm sorry I'm short on time, but just wanted to really quickly share this exciting new modality that will be coming up soon. So thank you for your time. I appreciate it.
Thank you, Dr. Burhan Chaudhary. We can take one question. Dr. Sara, please.
Thank you, Burhan, for that excellent talk. Two quick questions. One, say that a patient has, what is your way of dealing with this, that a patient has presented for the first time, say with optic neuritis, but the workup, MRI, LP, everything is pointing towards multiple sclerosis or relapsing remitting multiple sclerosis, but this is their first presentation. What would be your go-to medication? Would you start ocrelizumab now after the initial treatment with steroids and everything? And the second question is, once these patients have been on ocrelizumab and they have not had relapses, what is a good time to say, okay, they are in remission, and is it 2 years, is it 4 years? When would you stop treatment to wait and see?
Thank you. Really good questions. And so if I'm not mistaken, your first question was patient has had optic neuritis, but you also have a definite diagnosis of MS. Correct?
Yes, yes.
Right. Yeah. So Dr. Khan, I would in that case, the data has clearly shown going to a high efficacy therapy right away is very, very impactful. You should not wait. You should not wait to see if there's going to be another relapse or there's going to be more lesions on MRI. Personally, in my practice, I start these patients on high efficacy therapies. You have ocrelizumab available to you, so I would not hesitate in going to it. And it's tolerated really well. And especially in MS patients who are younger female patients, there's a lot of good data around safety in these, child-bearing age patients. So well tolerated, safe, and really, really effective in making sure that there's no more relapses and that the patient's prognosis will be much, much better. Your second question, that's also a very, very good question. And honestly, no one has the right answer right now. So typically, so chronic B cell depletion, as you are aware, does come with some issues as well, specifically in terms of infection. So if you've had someone who has been B cell aplasic for 5 years, 10 years, 12 years, exactly how long should that period be? We don't have any data exactly when that switch should happen. But if you have a younger patient who has been disease-free on okra for at least 7 to 8 years, it is, it's fair to start asking that question: how much longer do they have to be on it? There are two trials that are relevant to your question. One is it's called DISCO, where patients who are older than 55, who have been on high efficacy DMT for at least 5 years and are stable, they are being taken off. And then it has two arms. One arm is taken off and one arm is continuing. The interim results for that study were presented 6 months ago, and it was surprising to see that the outcomes for both arms was about the same. So stopping the treatment did not, as opposed to continuing treatment, outcomes were the same. So you could make a case that, hey, maybe you can stop outcomes. There's another study out of Penn where patients who have been stable on ocrelizumab specifically for 5 years, and they are stopping the DMT to see what the outcome will be. But to be safe, if you have a young patient, I would keep them on DMT at least until their mid-30s if they've been on a DMT for at least 5 to 6 years.
Thank you, Dr. Burhan Chaudhary, for giving us updates on this very important topic. Thank you very much. Hope to see you again. This was the last talk of the session. Now I will request Professor Naila Naeem Shehbaz for her expert comments.
Dr. Wasim is chairing the session. He is my teacher as well. So I think he must give the comments. Professor Wasim Saab.
Thank you, Naila. This session was very enlightening compared to the 30 years back when there was a stigma that neurological diseases are not treatable. Now we see that even very difficult cases are effectively treatable. In this session, the first talk was on autoimmune epilepsy conditions and how to manage them. It was very interesting and very enlightening. The second one was how to manage the refractory epilepsy and the super refractory epilepsy. And the third one, that how we can effectively use the high efficacy disease modifying drugs in multiple sclerosis. I think these were three very important talks and very enlightening.
Thank you, Professor Wasim Akhtar Saab. With this, we come to the end of this scientific session, and I hand over to the organizers. Thank you very much, sir. Madam, please.
I'd like to say thank you to Dr. Uruba, Dr. Amir, and Dr. Murhan for this very informative session. Now, since we have all the doctors here, I would like to say a huge thank you to everyone over here, especially to our chief guest, Dr. Mazhar Badshah, who has graced us with this presence.
Now, I would like to request Dr. Shahid Mustafa, the HOD department, head of department in Aga Khan Hospital, to please come forward to distribute shields to our expert panels.
We would like to start with the moderator of the first session, Dr. Muhammad Nasrullah.
Dr. Wasim Akhtar. Dr. Zareen Mughal.
And finally, Dr. Naila Nadeem Shehzad. Dr. Naila Naeem, can you please present a shield to Dr. Shahid Mustafa as well?
Just a quick correction. I'm not the head of the AKU. The head is sitting right here, Dr. Sara. Thank you.
Sorry for that. Thank you so much for everyone. Now we will have some tea to rejuvenate, and then we will continue with our second session in the next 20 to 25 minutes. Please enjoy your tea. Thank you so much. Tea is being served on the right side of the hall. If you would please move that way. Thank you so much.
So the tea break would be of 10 minutes. So we hope everybody comes back within 10 minutes so we can proceed with the session.
अस्सलामुअलैकुम मैडम, कैसी हैं?
कौन सी वाली? वो तो वैसे मुझे क्वेश्चन पूछे मैडम, नहीं उसने मुझे पूछने ही नहीं दे रही, मैं उसको पूछना चाह रही थी कि तुमने 48 आवर्स के बाद नोट किया था।
मैं इस बात पे हंसी थी शायद वो केस एक्चुअली इग्नोर किया गया था।
हाँ,
मुझे बता रहा तो मुझे तो आखिरी दिन लोगों ने दिखाया था। बहरहाल वो ये हुआ तो आपने ना ये जिस को मुझे पूछा कि आपसे क्या क्वेश्चनिंग हुई था, तो उस जगह बस मैडम मैंने बता दिया कि भाई मुझे तीनों को प्लान नहीं था, तो मैंने ना ये जैसे किया ही नहीं था। मैं हंस रही थी, मैंने कहा भाई तुम पहलों से बात कर रही थी, पहलों तो फिर सब कुछ पूछेगी। मैंने कहा चमक के कान पूछूंगी। मैंने कहा मैं कैसी, अरे यार इतने दिनों बाद तुम्हें देखा है, कैसी हो?
बस इधर ही इस्लामाबाद में। मैडम कहाँ पर वहीं देख रही हूँ।
मैडम तो तुम्हें देख के बहुत खुश होंगी।
वो बैग पे थी ना तो मुझे नजर
नज़र नहीं आई, हो सकता है टी वगैरह लेने चली गई
हाँ
हो।
शायद।
किस कलर का पहना हुआ है मैम ने
वाइट,
चश्मा?
बिल्कुल वाइट।
और कैसी हैं आप? वैसे तो माशाल्लाह और भी स्मार्ट हो। आप अभी उधर गाँव में, मतलब आप तो सिविल में हो?
हाँ मैं बहुत हेल्प करती हूँ। बता रहे थे कि हमने वार्ड डेवलप किया। कैसे आप खैरियत से हैं? मेरे ख्याल से आप लोग का तो विजिट हो गया ना तो वार्ड का। वो मेरे ख्याल से ट्रेनिंग के लिए हो गया ना एग्रीडेशन हो गई। चलो माशाल्लाह। तो वैसा भी प्रोफेसर हो गए। काफ़ी प्रमोशंस हुई है जब आप तो पहले हो गए थे। और सब खैरियत से? तो यहाँ पे जिस चीज़ की ज़रूरत है दुकान अवेलेबल है, आप नंबर ले लें, जस्ट लेट अस नो, वी आर अवेलेबल फॉर दिस। थैंक यू।
If we can please request everyone to be seated, we're about to start our second session. सबर करो नहीं वो उनको आने दो जो सामने बैठना है जिसने वो मैं बोल रहा हूँ वो मेरा कागज दो एक्सपर्ट पैनल है ना और ये मॉडरेटर
This line, then that, then this.
ये मैं बोल रहा हूँ ना
ये तुम बोल रहे हो?
ये तुम बोल रहे हो नहीं सर हमारी फोटो है ना आप क्या कह रहे हैं इधर से नहीं नीचे से हम नहीं देखेंगे नहीं मैं इससे पूछ रहा हूँ कि स्टार्ट करें स्टार्ट करें
नहीं मैं आने के दो किसको बुलाएंगे कोई आए तो बुलाएंगे Welcome back everyone, and I hope you have had your caffeine fixed because this next section will demand your full attention.
The panel of experts for our next session includes Dr. Nadir Zafar, Professor of Neurology and ex-HOD at Sheikh Zayed Hospital. Can we please have you on stage? Assalamu alaikum, sir. Where do I sit? Sir, whichever chair. Can we please have our second expert, Professor Khurram Haq Nawaz, Professor of Neurology and Principal of Army Medical College. Assalamu alaikum, sir. And finally, can we have our third expert, Dr. Fozia, who is a renowned epidemiologist at Aga Khan University. I would like to call on stage Professor Mansoor, who is the HOD of PIMS Islamabad, and he will be the moderator of this session.
This session begins on a solemn note. We now invite Dr. Ahmed Asif, HOD Liaquat National Hospital, Karachi, to deliver an obituary in the remembrance of the late Professor Nadil Ali Sayyid.
Assalamu alaikum everyone. It's an honor for me that I was invited to give a talk about Dr. Nadir. It was a blessed day of Friday. It was 8th of August 2025. The day has just started. When phone calls started ringing and message tones started beeping all over the country. The messages were like, Madam, ek afsos ki khabar hai. Sir, have you heard something? Madam, kya ye khabar sahi hai? What are you saying? Are you in your senses? A short while ago, emergency was declared at South City Hospital, Karachi. A patient was brought to ER at 6:20 a.m. He had collapsed in toilet early morning. All the related services, including critical care, cardiology, neurology, general surgery, pulmonology, were called. The teams immediately arrived and were trying to save a person who was dear to everyone. A 30 to 35 minute CPR was run on him, but the humanly possible efforts failed. Around 7 a.m. it was declared that he was no more with them. Inna lillahi wa inna ilahi raji'un. Everybody there was shocked, and no one was ready to accept the bitterest fact of life. The news spread all over the neurology community in no time. Nobody was believing. Every neurologist of the country and even abroad was sad, dejected, and their hearts were literally weeping. Perhaps the largest number of messages poured into the PSN forum ever on any one topic within a couple of hours that day. 2 days later, his janaza was one of the largest janaza that had ever been seen in Masjid al-Yathrab of DHA Karachi. And we all know that when a large number of people on earth give their vote of love to anyone who has left this world, it becomes a credit when the body reaches there. A friend, a mentor, a brilliant colleague, an advisor, a healer, a hero, and most of all, a noble gentleman whose life was devoted to caring for others, left for his eternal peace, leaving behind thousands of sad faces with flowing tears. A tall figure, athletic build, a friendly smile, a soft voice, calm and composed personality, and an everlasting sense of friendship were the hallmark of only one person that I know. He was Dr. Nadir Ali. He was born in Karachi on May 24, 1967. His family belonged to Lahore. His father, Professor Shaukat Ali Sayyid, was one of the pioneers of cardiology in Pakistan and was the founder director of NICVD, National Institute of Cardiovascular Diseases, which is one of the oldest and the largest state-of-the-art cardiac institute of the country. His mother was a homemaker. Nadir was only brother of 4 sisters. He was number 4 of total 5. Nadir got the best of this world. His early education was in Habib Public School, a reputable educational institute of the city, famous for its educational as well as sports standards. He then moved to Karachi Grammar School and cleared his A-level in 1984. In 1985, he was in Aga Khan Medical College, from where he graduated in 1990 as a batch of 90. He then proceeded to US and completed his neurology residency from University of Medicine and Dentistry, New Jersey, Robert Wood Johnson. Later at NIH, he completed his clinical neurophysiology fellowship under scientist emeritus Dr. Mark Hallett, a large researcher in the field of movement disorders who had worked with David Marsden. So, in other words, Nadir may be called as a spiritual grandson of David Marsden. In 1998, he returned back to Pakistan. The motivation behind the decision was to look after his parents. He was the only son to them. He treated his parents with dignity and compassion. Those who saw him taking care of his parents used to pray, "May Allah grant every parent a child like Nadir Ali Sayyid." After returning to Pakistan, he joined his parent institute as assistant professor. Dr. Shahid Beg was HOD then, and his peers were Dr. Aziz Sonawala, Tehseen Muzaffar, Mohammad Wase, Imran Wahidna, Aisha Kamal, and Saad Shafqat. Being part of neurology, he had an amazing influence. He was involved in developing neurosciences curriculum and chaired the university's neuroscience module committee. In 2005, Nadir was heading the Department of Neurology, and he remained on the seat up till 2008. During that period, he also served as Associate Dean for Postgraduate Medical Education. There, he took some drastic and memorable decisions. His colleagues still regard him as the best Associate Dean PGME. He took personal interest in solving salary issues of his co-workers. Some of his decisions were very bold and decisive. Biggest one was to hold convocation of AKU graduates. He was the only person who made it possible to hold a convocation of AKU graduates with complete exquisite arrangements and the way it is staged today. He was a superb mentor and a devoted teacher, always encouraging his students to reach the top. A number of them were motivated to pursue neurology only because of his amazing influence as a guide. In the clinics, he always insisted them to bring their own examination tools so that they become comfortable in picking up signs. He used to buck up and greet his junior colleagues generously on their successes. For years, he won the Best Teacher Award in AKU. He was always ready to help his mentees in the time of need and guidance. He was one of the most lovable tutors who had played a pivotal role in many fellowships and workshops. Nadir was a source of knowledge for his colleagues. I personally do not know any neurologist in Karachi who had not consulted his wisdom whenever they came across a difficult case. When AKU started stroke unit, the faculty was perplexed whom to call for inauguration. It was his advice that a stroke patient should cut the flap, and indeed it was a very unique way of inaugurating a unit. TP activity at AKU also started under his guidance. He played a central role in establishing specialized clinics like headache clinic in AKU, and he was an instrumental figure in establishing neurophysiology service and neurophysiology fellowship program in Aga Khan Hospital. The AKU authorities have decided to name the neurophysiology lab in honor of Dr. Nadir Ali Sayyed. In 2008, he decided to start private practice. He became part-time in AKU and joined South City Hospital as a clinician. And in no time, he was an advisor, board member, and partner. He established an active, thriving neurology practice there. He had a very loyal following of patients. His patients were not his patients, but in true sense, his murid. And he was a source of shifa for them. Nadir has a huge impact on the field of neurology in Pakistan. He never sought recognition, but he always left an unforgettable mark whenever he went. He never had any major post in PSN, but every core committee loved to keep him as his advisors list. His sensible advices always play a crucial role in solving difficult problems. He was the first movement disorder specialist in the country. He founded and was the first president of Movement Disorder Society of Pakistan. For years, his name was synonymous with MDSP. Nadir was MDSP and MDSP was Nadir. He trained a number of neurologists and conducted many courses and workshops promoting treating and care of movement disorder patients. Personally, he was a true gentleman and a man of principle. He always gave others utmost respect, irrespective of their rank and position, and appreciated their good work. Once, while trying to enter a corridor in AKU, he was stopped by the guard as he was not wearing his hospital ID. His residents tried to convince the guard, telling him who he was, but Dr. Nadir stopped them, saying that the guard was doing his job. Don't try to overrule him. It is my fault that I am not wearing my ID card. How will he know who am I? He was always an easy person to talk to, cheerful, laughing, smiling, cutting silly jokes. His friends used to say about him that he was yaron ka yaar. Going to gym, keeping himself fit, and riding motorbike were his hobbies. He had partitioned his life amazingly. He used to come to clinic in time and would complete his task with remarkable accuracy. He used to say, your time of professional life should be of your profession, and for the personal life should be with your family and with yourself and your family. Beyond his professional excellence, his greatest pride and joy was his family. For them, he was a constant source of love, guidance, and inspiration. His wife, Dr. Farah, who was his AKU classmate and is a pediatrician, he has left 4 children, 3 sons and 1 daughter. Eldest son is doctor. Taimur is working in a biopharmaceutical company in New York. Aman is a financial analyst. Raza, the youngest son, is studying economics in UCL, UK. Nadir was a highly competent, knowledgeable, and empathetic neurologist who always maintained an aggressive treatment approach. One may describe him as a true gentleman. He is a dedicated physician, a reliable colleague, a devoted family man, and an accomplished scholar. Dr. Aziz Sonawala is the only person who had a very unique association with Nadir. He worked with Dr. Sonawala first as a medical student, then a fellow worker, a colleague, then as department chief, and most of all as a sincere friend. Dr. Sonawala describes Dr. Nadir as an outstanding professional who had a very systematic approach towards life. He was always an encouraging and cooperative colleague and a very kind-hearted boss. He recalls that once they both were out in a conference and Dr. Sonawala needed daily IV injections for which no medical assistance was available. Nadir used to go to his room daily morning before the sessions and administer his IV injectables. We are all sad today. Nadir will be remembered not in sorrow, but with gratitude and passion. After passing a very dynamic, joyful life, the silent hero moved to his last home. All our praise are for him. May his soul rest in eternal peace. May all his loved ones granted strength in this time of profound loss. He got the best in this world. May he get the best there too. I'm grateful to all those who helped me in preparing this write-up. I'm in debt to Professor Saad Shafqat, who contributed maximally, and without him it would not be easy for me to get all these knowledge. I'm thankful to Dr. Aziz Sonawala and Dr. Dureshawar, who read the whole questionnaire and tried to answer whatever they knew. Thanks is a very small word for Dr. Farah Sayyed, who with all of her emotions reviewed the manuscript and made valuable corrections. Thank you.
Thank you, Dr. Ahmed. Professor Nader Ali Sayyed's legacy reminds us that while conferences like these are about the future, they're also about honoring the people who paved the past for us.
Now with that spirit, it is my pleasure to invite President of Pakistan Society of Neurology, Dr. Naila Naeem Shehbaz, to deliver the President's address.
Assalamu alaikum. All those who are present here and all those who are online viewing this conference. Our conferences, our neurology conferences, although they, like any other conference, they are a source of knowledge and they always update us in our knowledge and our clinical practice, but they have a special touch as well. They are our social, they are booster for our social ties. And many of those whom we consider to think, हम सोचते रहते हैं उससे भी बात करें, उससे भी बात करें, लोग याद आते रहते हैं, लेकिन time नहीं मिलता. I think everybody has a busy schedule and we usually जब हम यहाँ आते हैं इस कॉन्फ्रेंस पे अपनी न्यूरोलॉजी की, वी आर एबल टू सी मैनी ऑफ आवर फ्रेंड्स एंड मैनी ऑफ आवर कोलीग्स जिनको हम सारे साल याद करते रहते हैं. सो इट इज़ अ फर्स्ट ऑफ ऑल आई मस्ट thank all of you who are here to attend the conference and making it a success, and congratulations to Dr. Babar and Dr. Aslan and team that for a conference which is showing every signs of success from the first session. And I can see that it was very well planned. Although they were given a very short notice to arrange this conference, they have done very well, remarkable arrangements. And with this, I would also like to tell you that understanding the needs of communication and knowing each other, हर दूसरे तीसरे दिन किसी का मैसेज आ रहा होता है, गुजरानवाला में कौन है neurologist, मुल्तान में कौन है neurologist. Considering that, we have started a neurology की एक digital directory, which I think is secondary to after you register yourself for the register yourself as PSN member. और जब आप लोग and I am really grateful for that for Helix Pharma in assisting and registering our members. So I think I request all of you, all those consultants and neurologists and faculty members, to please register yourself so that we can this is not only a digital directory, it is our first database जिससे हम आप एक दूसरे को तलाश कर सकेंगे, हम उनकी प्रैक्टिस की जगह देख सकेंगे और you are able to edit your profile as and when you change your location or your designation improves. जिस तरह ये सारी चीज़ें होंगी तो you will be able to improve your profile as well. So this is digital directory of PSN, and I think everybody must register. Registration इसलिए भी ज़रूरी है that we have decided in our last executive committee of the Pakistan Society of Neurology decided in our last meeting that every member will have to renew their registration on yearly basis, and this is little service which you can do to your society by being standing in good standing. So that is and today we have also planned a general body meeting, and I expect all of you to be there, all the consultant neurologists who are registered with us. We expect of all of you to be there with in the general body meeting, and we are expecting you to give your opinions and your suggestions. How can we improve our services and our social ties? So I think that is all that I wanted to say. Thank you very much, and congratulations again to the organizing team.
Thank you, madam. Now to start the session, scientific part of the session, our first speaker is Professor Saad Öztürk, who has from Turkey, and he has come all the way from Turkey just for this conference. First of all, I must thank him, and let's have a huge round of applause for him. So, sir will have talk on, sir is a professor of neurosurgery with special interest in neuromodulation, and he will have talk on neuromodulative surgeries, rising trend in neurological diseases. Over to you, sir.
Good morning. First of all, thank you very much for the invitation of organizing committee, and it's my pleasure to be in Pakistan to share my knowledge with you. And I will speak about the details of neuromodulative therapies. What's the meaning of neuromodulation? First of all, I would like to start with this. So sorry, I will extend the okay. The neuromodulation means in case of any impaired neuronal activity, we are giving external energy to peripheral nerves or brain to modulate the interrupted electrical activity. And mainly we are using these therapies in the treatment of movement disorders and drug-resistant epilepsy and depression. Which patients are proper for the best result? For this reason, to select the best patient, we should work as a team. And the neurologists and psychiatrists are the main rollers of this team. And for a Parkinson patient, at least 3 to 5 years L-DOPA medication is essential for us. And if the patient has dyskinesia, also it's an indication for the deep brain stimulation. And DBS is more effective in patients with good response to L-DOPA treatment in the beginning of the disease. And the main contraindication is atypical Parkinson disease or uncontrolled psychiatric problems. So in Parkinson disease, we are stimulating the subthalamic nuclei. In the treatment of dystonia, we are stimulating the globus pallidum interna. And ventral intermediate nucleus is the best target for the treatment of essential tremor. With the advancement of the radiological techniques, nowadays we are using 3 Tesla MRI, and by the way of 3 Tesla MRI, we can see easily the target. But in case of 1.5 Tesla MRI, we should use
this slideshow.
Sorry. I don't think.
think.
Yes, it's okay.
It's okay now, sir.
Okay.
It's okay now, sir. You can
Thank you.
continue.
So it's important to selecting the target, and it's important to get a high quality MRI. We are making this surgery under two stages. The first stage is implantation of the electrodes, and the second stage is implantation of the IPG. Before surgery, we are getting the MRI, and we are using a high technological software, and you see the software here, and 3D nucleus, and then we are making the planning by this software. So these softwares are very important software for us. And beginning of the surgery day, we are implanting a stereotactic cable, and then we are starting the surgery awake. Why awake? Because of two reasons. The first reason, we are mapping the deep brain nucleus during surgery. We are mapping it. And then we are defining the target, and then we are starting to giving electrical activity. My videos are not working, so sorry. And then we are checking the possible side effects and how many ratio of effect we get during the surgery. I'm so sorry, but my videos are not working now. Yeah, it's not working. I think it's related with the connection, so sorry. So we are making this surgery for Parkinson, for essential tremor, for the dystonia, not only for the adult patients, but also we are making these surgeries in pediatric patients. So these surgeries are one of the safest surgery of neurosurgical procedures, but of course we are implanting cables. For that reason, there is a risk of 1% of infection and lower than 1% of hematoma, and the mortality is extremely rare. Now we are using the rechargeable systems. What's the meaning of rechargeable systems? We are using high technological systems, and these systems are rechargeable, and the life of the battery is at least 15 years. And there is no need to make charging every day like a mobile phone. Just one time per week, the patient should make the rechargeable system 1 hour, and we need to change the system at least 15 years later. So I want to speak about the epilepsy. You know, epilepsy is one of the most challenging disease of all population, and the approximate incidence is 1%. And most of the patients can be treated by the medically, but 30% of the patients cannot be treated. So for that reason, most of the patients cannot be suitable for the surgery because of some reasons. The most important reason is we cannot identify the epileptic focus, or we can find, but it's located in a functional area. For that reason, we cannot make a resective surgery. I would like to give details about the Pakistan. The population of Pakistan is approximately 250 million, and 1% is 2.5 million epilepsy patients you have now. And the drug resistant of these patients are near to 1 million, and 500,000 patients needs neuromodulative treatments or surgeries. So the first neuromodulative therapy in the treatment of epilepsy used before Christmas. And with the torpedo fish, you know the torpedo fish has an electrical transmission organ. In case of epileptic activity, the fish is contacting with the patient. So Avicenna also used this therapy many years. And the first modern VNS surgery performed in the 1988. And really we don't know how does it work, but we have some hypotheses. The most accepted hypothesis is neurotransmitter chains, cerebral blood flow, and desynchronizing of the EEG. Again, my videos are not working, so sorry. So we are making VNS surgery under general anesthesia and supine position. The patient has two different incisions. The first incision on the chest is for the implantation of the battery, and the second one is for the implantation of the lead. Skin and subcutaneous tissue transferred, and then we reach to the carotid sheath. You see on the medial side carotid artery, and on the lateral side bluish color is jugular vein. And then we are opening the sheath and we reach to the vagal nerve. Approximately 4 centimeters dissected vagal nerve is enough for the implantation. Also, this video shows us the microscopic picture of the system, and then we are implanting the IPG, but sometimes we can see some variations. In the literature says that the variation of the left-sided vagal nerve is extremely late, but it's not reality. We have operated nearly 350 patients, but we have 5 variations. One of them is Y-shaped vagal nerve, and also in 2 patients we see the vagal nerve outside of the sheath, and in 1 patient we see the non-recurrent laryngeal nerve on the left side. For that reason, using microscope is always important. Now I want to give information about the effect of the DBS in the treatment of epilepsy. Also, we don't know how does it work, but the just accepted mechanism is direct stimulation of Papez circuit is essential for us. So the first accepted, cornerstone publication is this publication, the stimulation of anterior thalamic nucleus, and then the Sante study is the best study, and after Sante study, FDA approved the DBS therapy in the treatment of epilepsy. So, first years in the beginning of the DBS epilepsy, just we are stimulating anterior thalamic nuclei, but then we changed our strategy. Now, not only anterior thalamic nuclei, but also mammillothalamic tractus stimulation gives us more satisfactory results. So, the main disadvantage of this surgery is we are implanting the cables from transventricularly. This is our only disadvantage, but now we can make transtemporal implantations. And I would like to show you the long-term results. Now, on the market, we have VNS, DBS, and RNS. In Turkey, we don't have RNS. For that reason, in the last 10 years, I have operated patients, and I want to show you the comparisons. In VNS, DBS, and RNS, at the end of 6 months, the responder rate is similar ratio. But in long term, in the 5th year, you will see DBS responder rate is 78%. For that reason, DBS is more logical. But the main disadvantage of DBS is, compared with VNS, it's a little bit invasive because you are implanting cables inside the brain. Also, the replacement is same risks for VNS and DBS, but in RNS, we are implanting the neurostimulator inside the skull. For that reason, in case of replacement, we should make a craniotomy. Also, VNS and DBS is MRI compatible, and the main advantage of DBS is life of battery. Why? Because in DBS systems, we have rechargeable effect, but in VNS, it's non-rechargeable. And when we check the side effects and the complications, VNS has low side effects. Just we have voice problems, but most of them are temporary side effects. But in DBS, the main problem in the long term is memory deficit and some emotional problems. And these ratios approximately 5 to 7%. So teamwork is essential for the success of movement disorders and epilepsy. Resective epilepsy surgeries are our priority always, not its first step. Main objective of neuromodulative techniques are not completely treating the epilepsy. Also, expectations of the patients and parents are extremely high. Sometimes a VNS surgery takes maximum 1 hour. But before surgery, I am speaking with the family. Also, our neurologists speak with the parents of the patient more than 1 hour for the expectations. And the effectiveness of neuromodulative therapies increase over time compared with the anti-epileptic drugs. And this message for the neurologists, please do not think neuromodulative techniques are the last chance, and please do not delay this technique. It's very important. And which technique is best? For my experience, it's so difficult to put a stereotactic frame in a 3 years old, 4 years old child. For that reason, in pediatric patients, for the treatment of drug-resistant epilepsy, I'm using VNS, but for the adult patients, I am performing the anterior thalamic and mammillothalamic tractus stimulation, my first option. And again, thank you very much for your patience. First time 2021, I was in Alhan University with the aid of Professor Fevziye Sadık. He's my big sister. And then every year I am visiting there regularly for the increasement of the awareness of these therapies. And again, thank you very much for your patience.
Thank you, sir. Sir, I'm hopeful that such sharing of knowledge between the two countries will strengthen our brotherhood and friendship between Pakistan and Turkey. And we can have one or two questions. Professor Bashir is going to ask.
I am Bashir Sumro and practicing in Karachi, Pakistan. So I just want to ask you how much the cost in terms of Pak rupees we can send the patient towards your centers. So because there are a lot of patients who are on the waiting list, and one of our neurologists who is from Pakistan, he is doing in Turkish. And my team, Dr. Shazma, she is the one, she monitors the DBS at clinics in our center. So can we develop a liaison in between your center and our centers to refer the patients? But we need to have a, in terms of money and PKR.
Yeah.
Cost.
Yeah.
Can I just, number one, Dr. Seth was just here last week. I mean, just like 5 days ago. And he's back here, for which we are very, very grateful. So he was actually performing these DBS in Aga Khan, and we're doing it now very frequently. And we did go through a discussion on this, that which would be more cost effective. So obviously doing it over here would be more cost effective than going, because then there's the airfare and then there's the stay that they will need over there. And on the whole, the device cost was pretty much the same, probably cheaper in Turkey. It's around 9 million. 9 to 10 million overall cost.
You see some of the patients, they are very reluctant to go to the Pakistani centers.
Yeah.
Yes. In Karachi, we have two centers.
It amounts to pretty much the device cost,
And
and
the device,
the extra is the stay and the airfare.
And their devices are Chinese versus Western device.
No.
So
we use the same Medtronics. Medtronics.
Yeah, also the Chinese products are not cheaper than the American one. I don't know why. Yeah, not too much cheaper. But the main problem, like our countries, like Pakistan, like Turkey, is we are not developed countries. We are developing countries. For that reason, the cost is our most limitation problem for these surgeries.
Thank you.
Yeah, luckily we have the videos online, so if you could show
Sir,
them.
I have one question for you regarding neuromodulation in epilepsy patients. As you told us that you performed 350 cases of DBS and 13 cases of the vagus nerve stimulation. Probably I missed the success rate of your neuromodulation techniques in epilepsy patients. And what was the age group of your patients?
Excuse me, I didn't understand your question.
As you told us,
he's asking the success rate of neuromodulation in epilepsy, which you showed in the long-term
age
results.
group of your patients.
Yeah, all these patients are in epilepsy section is epilepsy DBS. And my observation is, for example, if we make VNS, we should wait at least 6 to 8 months to see the first result. But in DBS, in the second week, we get the effect. And all the patients say that at the end of first month, I feel everything is a little bit more better. Yeah, why? Because in VNS, we are giving electrical stimulation indirectly from vagal nerve, locus ceruleus, brainstem, cortical area. But in DBS, directly we are giving electrical stimulation to the anterior thalamic nuclei and directly Papez circuit. For that reason, we get early effect in the DBS systems.
Is there any age criteria do you opt?
I'm so sorry.
Age of your patients, age.
Age.
Yes.
Yeah, age related. The FDA approved DBS epilepsy in 18 and more years old.
Thank you.
And VNS can be any age, I think 6 and above?
No, for
what
VNS,
is the youngest VNS you've placed?
For VNS, 4 years old. Now,
4
4 years old. Also, I have 3 patients younger than 4 years old. But the main problem in newborn, or the main problem in the years younger than 4 years old, the calibration of the vagal nerve is not enough to put an implantation. So my videos are now working. I'm so sorry. I want to take 2 minutes more. This is the implantation process of the VNS. First of all, when we open the system, and then you see the carotid artery first of all, and then you will see jugular vein and the vagal nerve. So this lead has 3 different spiral-shaped parts. First of all, I am starting from the lowest one, but it's not essential. It's up to your experience. Always I am performing this surgery under microscope. It's very important for us. Why? Because we should not be harmful to nerve. Also, we should preserve the blood supply of the nerve. It's so important for us. Because if you make a rough surgery, if you disrupt the vascular structure of the vagal nerve, it's not a good option for us, because the important thing is transmission of the electric to the superior side. And just I want to show you examples of Parkinson patient. This patient is, unfortunately, this patient passed away during the pandemic. The main problem of the patient is rigidity and bradykinesia, not tremor-dominant Parkinson. On the left side, you see stimulation off, and on the right side, you see stimulation on. And the other patient is, again, Parkinson patient. The main problem is tremor-dominant Parkinson. Again, on the left side, stimulation off, right side, stimulation on. And this patient is also tremor-dominant Parkinson disease. And this is the example of essential tremor. This is the example of essential tremor. On the left side, stimulation off, on the right side, stimulation on. And just I want to show you a pediatric patient, and then I will finish my lecture. Also, we are performing this surgery awake. Why? Because we speak with the patient, and we are mapping the deep brain nuclei, and then we are temporarily giving electrical activity to check side effects and the clinical effectiveness. So on the right side, I will show you before surgery. This video sent us by his family before surgery. And just 2 months later, now you can see the patient after surgery. Again, thank you very much for your patience.
Dr. Seth, was this patient with a single DBS or?
Yeah,
Just
GPI
a single
DBS.
or both sides?
No, both sides.
Both sides,
Both
right?
sides.
Yeah,
because
because
this is
that's
primary
bilateral
dystonia.
result, yeah.
This is primary dystonia. For that reason, we are implanting both sides at the same time.
And we can't use just one battery for both sides. We have to have 2 batteries.
In all patients, I am performing both sides, because these diseases neurodegenerative diseases. But if it is secondary dystonia, just only one side is effective. And if the general condition of patient is not so good for the toleration of the surgery, maybe we can select unilateral stimulation. But in young patients, if the patient is primary dystonia, we know that in the future other side will be affected. For that reason, we are implanting both sides.
But both 2 batteries, 2 separate batteries, one here
No,
and
no,
one
no.
here, or just
No,
one battery?
in Turkey, social security system is supporting only one device.
Right.
For that reason, we are using unilateral implantation, but both sides lead implantation.
Oh, okay. Great.
Thank you, sir.
Thank you.
So, especially for thanks for Dr. Seth, Professor Seth, and his talk has generated so much discussion that I'm thinking that he must be invited in the next conference as well. So our next session is by Professor Atar Javed, who is teacher of the teachers and ex-professor of neurology at King Edward Medical College, University, and now heading the neurology at National Medical Center. He will be talking about immunotherapy in neurology. Over to you, sir.
Bismillahirrahmanirrahim. Assalamu alaikum, everybody. And I'm grateful to Professor Arslan and Professor Babar for giving me this opportunity. And this is very important talk. As you know, since morning we are talking about immunotherapy, whether it is epilepsy, whether it is multiple sclerosis. So it will be a summary of what we have been talking since morning. So first thing is, what are the neuroimmunological disorders? Basically, these disorders, they result from complex interaction between nervous system and the immune system. And the result is that the immune system, like a friendly firing, produce antibodies which instead of killing the viruses and bacteria, they are directed against own nervous system. And finally, it can affect your brain, spinal cord, peripheral nervous system, including nerves and muscles. So with this background, there has been revolution in immunotherapy. Now the older concept was immune privilege, that certain organs in the body, they are prevented from attack by the immune system. And these included nervous system, cornea and uterus. But with passage of time, this proved to be a wrong theory. Now we know there are discovery of antibodies which are produced against different nervous tissues, like we have autoimmune encephalitis, we have oligoclonal band, we have NMO, spectrum disorder with aquaporin 4 antibodies, and we have MOGAD, right? So with this disease, when we knew the number of antibodies produced again, then there are targeted therapies came and which were named as immunotherapies. So with this background, so what are the different immunological disorders which can be treated? There is a long list. You can add few cases every day, but most commonly what we are doing is there are multiple sclerosis, neuromyelitis optica disorder, MOGAD syndrome, myasthenia gravis, autoimmune encephalitis, and vasculitis associated with central nervous system or peripheral nervous system involvement, GBS, CIDP, inflammatory myopathies, and stiff person syndrome, and even the progressive multifocal leukoencephalopathy is also being treated with immunotherapy and paraneoplastic syndrome. But you can add, and this list will increase. And what is the consequence of this one? There is a paradigm shift. Like the things which we used to say they are not treatable, you can only offer symptomatic treatment and physiotherapy. Now we talk about disease modifying therapies and a possible cure even in advanced malignancies of the nervous system. So what are the different modalities which we label as, which come under the category of immunotherapies? These are all we know commonly used as steroid, then non-steroidal immunosuppressive agents like amorin, mycophenolate, and various other drugs, IVIGGs, plasma exchange, monoclonal antibodies. And this is the era where I will more, where these are more causing success in immunotherapy, and I will talk about more about this category, and then immune checkpoint inhibitors, cytokine modulators working against different kind of interferon like IL-6, and then thymectomy and cell-based therapy, which Dr. Burhan this morning also talked about. Apart from autologous hematopoietic stem cell, they are CAR T cell therapy. And I think future belong to these last two categories in terms of recovery of neurological disorders. So when we talk about monoclonal antibodies, what are these? These are man-made protein that acts like human antibodies and in the immune system. And there are different sources they are produced, like some are from murine sources, and they can be recognized by the last 3-4 words, like OMAB. This indicates purely murine origin of monoclonal antibodies. Then chimeric, they are combination of, they are human and murine, and they are recognized with the last name of ZMAB. And finally humanized, where most of the component is human and small portion is murine, and they are ZooMAB. And finally purely human origin monoclonal antibodies are called UMAB. And you will see the list of these drugs. So I'm not going to talk about this thing, just to give you an idea that what is immunotherapy. The first disease which was where the disease modifying therapy in neurology was used was multiple sclerosis. When I started neurology, we were very happy when the beta interferon came in 1993. And the list is going to keep on getting bigger and bigger, and by 2024 we have about 27 modulating therapies. And the last 3-4 I just mentioned is they are the CD20 ublituximab. This was approved in December 24, and then we have biosimilar product natalizumab, and which was approved in August 23, and the last one was Ocrevus subcutaneous preparation, which was approved last year. And I was just talking to Roche, they say it may be available in Pakistan. This is to avoid this inconvenience of infusion going to hospital. So this is self-injected subcutaneous preparation. So I'm not going into detail. Dr. Birhan has long talk on this one. So this is which one. There are certain drugs which are highly efficacious and there are low efficacious. Which one to choose? Actually, decision is not primarily of a neurologist. You have to discuss this with the patient, and you have to take consent to which one you have to tell them the benefit and the risk, and then the patient has to decide whether they are going to opt this highly efficacious therapy or low efficacious therapy. This is just to summarize all those, because most of the talk will be on monoclonal antibodies, CD20 depleting cell therapies, and now we have a list. Initially the oldest one is rituximab, and now we have second one was ocrelizumab, and now we have 2 more, and they are all CD20 depleting monoclonal antibodies. Although rituximab is not approved by FDA, but you can go, there are large registries, there are used people, individual datas, but still not approved. Then next common disorder which we face as a neurologist is the neuromyelitis optica spectrum disorders. And we all use steroid, we all use plasmapheresis, and we use IVIGs, and long term with non-steroid immunosuppressant. So this is being used and still using it. But if you look at the FDA approval, now FDA does not approve all these are all off-label. Now the 4 drugs which has been approved by FDA, they are basically, they are eculizumab, and then ibilizumab, and then sertolizumab, and these are working against complement C5, and one is CD19 and interleukin 6. So these are the new drugs, and the FDA has approved these 4 drugs for the prevention and disease modifying therapy and prevention of relapses in neuromyelitis optica disorder. But this is just to update you, but that does not mean that we are not using these one, and these are the newly drugs. I have only one patient, they are very costly, like this Oplizna, it costs about 30 million per year, whereas rituximab costs about 80,000 treatment for 6 months. So this is very, the 30,000 per year. So the cost is very much. The efficacy, I think longer trial will tell us whether, because there are no head-to-head trials between rituximab and other drugs. So these are the FDA approved monoclonal antibodies, and you see, although rituximab is being used, supported by the trials, real world, but it is not approved by the FDA. It is cheaper, available in Pakistan, but the FDA has approved other 4 drugs so far. Now, another explosion or total new recommendation has come in treatment of myasthenia gravis. So I'm surprised that myasthenia gravis research is even more advanced than the multiple sclerosis. Now the concept is not only that the antibodies, they produce and they block acetylcholine receptor antibodies and they cause myasthenia gravis. Now the things have gone beyond it. They have gone into pathophysiology and pathogenesis. That it is these, and there is also complement activation, which result in lysis of the membrane and worsening of myasthenia gravis. There is detection of the neonatal Fc receptors, and they are responsible for continuous recirculation of the antibodies which cause myasthenia gravis. So now we have drugs, and finally beta cell activation lead to more production of antibodies. So these are the few mechanisms, and now the drugs are available, and the concept is you have to hit those areas which may be involved. And so we have drugs which are complement C5 inhibitors, and these are the drugs which are available for that one. 2 are monoclonal antibodies. The Xyloco plan is a synthetic peptide, but it blocks C5 complement system. Then we have FcRn inhibitors, and there are 4 drugs which are available in this categories. And then we have 1 drug which is not approved by FDA but frequently used for beta cell depletion and modulation. And these are the various trials which have proven their efficacy, like RAISE trial, Champion, Regain, and where these antibodies work. So when to use, which one to use? Again, you start with standard therapy with steroid, non-steroid immunosuppressant. If they fail, you add CD20 depleting cells. If they fail, then you have to, if 12 months there is no remission, then you have to switch to either complement C5 inhibitor or neonatal Fc receptor inhibitors to improve the, but the role of IVG as a regular therapy is not recommended. It is only meant for the myasthenic crisis and worsening. And there are various guidelines, and the latest guideline which is published this month is by the Association of British Neurology. It's a very good guideline. If you look at this guideline, they have given all the doses of steroid, doses of immunoglobulin, plasma exchange, thymectomy, and a very extensive and very simple written guideline with lot of tables in it. So you must update that one. Then rituximab, since we use it more frequently in Pakistan, so I will just go that we have other conditions which where experience is good, like using in autoimmune encephalitis, associated SLE associated with neurological complications, chronic demyelinating neuropathy, which are refractory to standard therapy like steroid, IVIG therapy. So it is used as a second-line therapy for that condition as well. And then Alzheimer's disease. We have monoclonal antibodies which has been approved for early stages of Alzheimer's disease, and this is being used, but it requires special investigation, special criteria. So the first one was approved in 21, but this was later on controversial approval, and the company has Biogen withdraw this one in November 24, but we have launched lecanemab and donanemab. And recently, just before I was coming here preparing this talk, they have lecanemab subcutaneous preparation, self-injector for those patients who has completed 8-month treatment on lecanemab infusion. So the result shows significant improvement, like 68% reduction or clearance of amyloid from the brain on PET amyloid, and then reduction in cognition, improvement in cognition 27%, and 37% in their activity of daily living, and the progression is slowed down with these drugs, 31% risk of reduction to second stage or progressive stage of this one. Now, progressive multifocal leukoencephalopathy, like again, one of the drugs which has been used, small individual cases, and the larger series was in this New England Journal of Medicine, Keytruda. This is also one, and this is the study which was published for this one, and it has been found to be effective in those, apart from, because most of these cases are HIV, so you have to have hard treatment and you treat them primary disease, but those patients who are continuing to get worse, you can, this is one. So last few minutes I will take about rituximab, because I found that when the patient comes to me, they have so many questions on this one, and when I see that maybe the internet and the chat GPT has increased the knowledge of the patient. So basically this is chimeric, as we say, rituximab. So this is ZMAB, is chimeric, which is mouse and human antibodies, are working against the CD20 proteins on the B lymphocyte. And the mechanism of action are multiple. First, it causes depletion of the B cells labeled with C20. And second, there is apoptosis, and then activation of complement and lysis of the cell. So I will just go through this one because I think these are the basic things, but I am very much interested that when we use this one, we have to have certain pre-treatment assessment of rituximab, and these are the protocol that we do for each patient, and vaccination is required. If patient has, you should give them, patient need this one 4 weeks before you start rituximab. So you work up, consider GC testing in certain cases, like MS patient who has a high risk of this one. I have one patient with MADSAM neuropathy, wanted to refractory to all the treatment. So when we did JC virus, it was positive. So that is a contraindication to start this one. So there are different protocols, but the most common protocol neurologists use is 1 gram, 0, 14 days, and 6 monthly. But oncologists have a different protocol, rheumatologists have a different protocol, and then you repeat it after every 6 months. Now, with this, you give certain pre-medication like methylprednisolone, paracetamol, anti-allergic, and then infusion is given slowly, like 0 to 30 minutes, you have 50 milligram per hour, and then every 30 minutes you double the dose till you have maximum rate of 400 milligram per. And monitoring is very important, like you monitor white cell 15 to 30 minutes during infusion and 1 to 2 hours after the infusion. You watch for any hypersensitivity reaction, dyspnea, chest pain. Post-infusion, the question is whether you should do CD count or not. So I had one patient, 40 years, anti-muscle myasthenia gravis. So she had this internet access, chat GPT. So she read about CD20 and she got it done, CD20 count, which was 0. So she consulted another neurologist thinking that she is not due for this one. So my question, will you, with this count, will you give her rituximab or not? Answer, how many people will say yes or no? Because these are the practical things you face every day. So she was advised, no. If you get another count, you will be depleted. So she did not receive. So after 2 months, she has relapse of MS. And she had previously crisis, was in ICU, and now she started again breathing. So it is not. This is your target. So I personally don't like to monitor CD20 because 0 to 0.5 is the target. When it comes to 1% or more, so your drug is not efficacy. I will do other way around. If patient is not responding, I will do CD count whether this drug is working or not. So this was another thing. Then I talked about fit dosing. You have to do. An important precaution is that vaccination. Usually you do it if there is reactivation of hepatitis B, C, so you have to stop this one. And secondly, certain cases you give prophylaxis, like if patient is combination of steroid, so you give them pneumocystic RNA prophylaxis or antiviral prophylaxis, patient has history of herpes zoster infection. Now, how much time does rituximab in fact injection takes to slow down this, to deplete this CD20 count or CD19 count? कितना time लगता है? 1 day, 1 month, 6 months? Anybody? कितना लगता है? So, it takes only 24 to 28 hours when the CD count rapidly decreases by over 90%. So it's very quickly acting drug, and or interestingly, हम देते तो CD20 depleting therapy है, but CD19 count falls parallel. So you can only measure CD19 that will reflect CD20 as well. So, and restart करती है repopulation usually 6 months. Some patient 9 to 12 months. So if you delay, do not follow the schedule, this will have poor response and recurrence of the disease. So regeneration in 6 month time. So rituximab and pregnancy, because most of the patients are young female. The question is, they come to me and they ask me, are we allowed to have conception or not? Is there a chance of congenital malformation? So will you allow conception or not? Yes, no. Or is it causing congenital malformation? Although it does not increase the risk of fetal malformation, but generally recommendations is you avoid during pregnancy. So you must give the last dose 6 months before the conception. And pregnancy outcome, generally not affected. So there are reports preterm births, but there may be several other reasons in patient not related with rituximab. And neonatal side effect. So patient can have some patient who you need to continue during pregnancy due to their disease severity. Then you should measure the neonatal CD count. They may have B cell depletion, but it does not mean that they will have very severe infection. You just keep them under observation. So these are the guidelines I mentioned below, that based on this one, that generally avoid, but if the disease is that you can continue, and then you can measure the CD count of the newborn, and then you can continue. Then next question is, would you allow breastfeeding once you start this rituximab after the pregnancy? So would you allow breastfeeding or not? Yes, no. So transfer to the milk is very little. Like it is not even measurable in the breast milk. So feeding is allowed because this is a large molecule and very low levels are seen. So these are again recommendations from 2025 that American Academy of Pediatrics, that breastfeeding can be allowed while on rituximab. So this is my personal experience. I deal with 2 hospitals, Central Park Teaching Hospital and National Hospitals, but most of the patients I refer to Central Park because of the health card. There the drugs are available, including Ocrevus and rituximab, free of cost. So that is an advantage. So I have total of 122 patients, but most of the patients are on Ocrevus and some are on rituximab. I have 1 patient on inebilizumab and 1 patient on another CD20, which is called Kisemta. Of atomumab, this is Kisemta. This is very 20 milligram subcutaneous self-injector every monthly. So it's a very simple regime rather than going to hospital getting Ocrevus infusion or rituximab infusion. These are the number of cases. I developed this department in 21, so no case in 21, but 22, 4 cases, and the number is gradually increasing. This year, so far, we have 70 patients, and on rituximab, about 19 cases. So this is the workup only on rituximab. 32 patients, MS 8 patients, NMO 5 patients, myasthenia gravis 9, CNS vasculitis 6, and mononeuritis multiplex with SLE1, autoimmune encephalitis LG11, and cranial mononeuritis multiplex 1. So overall, this one, and the best response was seen in patient with myasthenia gravis. Yani almost all patients went into remission. And only one relapsed, this one, because she delayed her dose. So otherwise, and the worst result were in CNS vasculitis. One patient died, she is a partial response, and 2 of patients we have to shift to cyclophosphamide. So this is what my experience is. And just, this is not part of this one, but just to share this one, because sometimes you have to tell the patient, and sometimes they insist, and by default, you get the credit. Now this patient, both parents are doctors, own their own hospital. Their child has chronic cerebellar ataxia, slowly getting worse. They came to me. I diagnosed most likely this is Friedreich's ataxia. I asked them to do genetic testing. This is their second prescription. And if it is positive, there is a drug which is available since 23, Sky Claris, and provided genetic testings are positive. But they insisted, no, we want to start therapy anyway. They listened to me, they got this genetic testing which came positive for Friedreich's ataxia, and I prescribed prescription with the note. If you look at the bottom, I said prescription is issued on the request of mother while waiting for the test. So because I thought this is unethical to prescribe, but she was doctor, she said, okay, we will only use. But she managed to get this Sky Claris, and this patient has completed 1 year on this therapy, 3 capsules before breakfast, and he has lot of improvement in functional activities, going to the universities, doing all the activities. So this is just to share that the future belongs to not only immunotherapy, but genetic therapy as well. So this is my first experience with this patient. So I will just conclude here that immunotherapy is future of therapeutic neurology, paradigm shift to no treatment to possible cure in future, fiction to reality, despair to hope, and finally message for Dr. Naila and Dr. Babar is that I think we need part of this PSN, as we have PSS and Headache Society, now we need to have neuroimmunology and genetic society. Just to introduce my team, currently this is my team, and previously Dr. Kudsam is here, and Dr. Ahmad and Dr. Vikas has gone to UK for their further training in neurology. So this is my combined team from National Hospital and CPTH. Thank you.
Thank you, sir. It's always a treat to listen to your talk. You make complex things so simple and always talk about practical aspects rather than theory. Thank you, sir. Can we can have any questions? If there are no, I think next last speaker for today, Professor Yasir Ayaz, who is PhD in robotics, and he is the director for National Center for AI. So he will be talking about the trending topic AI in neurology. So artificial intelligence is going to take everything. So it's coming in neurology as well.
Let's hope so. Assalamu alaikum and good morning, everyone. I hope you're all doing well. Apologies that I was a little bit late, because of which my talk had to be switched by one number. So I'll be speaking to you about a topic which is very close to my heart, and we've been, trying different sort of interventions and different sort of applications in AI in neurology for a long time. And you'll see some of, I'll start with, where AI in neurology is coming from, where it is going, what sort of applications are there, what are the global market trends, and then we'll focus on some of the applications that we are working on and different areas, for example, in rehab, for example, in treatment of autism, and other devices that we've created, what sort of work we've been doing related to AI in neurology. So without further ado, first of all, introducing about artificial intelligence, we all know that AI is the big thing right now. Actually, it would be wrong to say it's the next big thing because it's the biggest thing right now, right? So if you look at the overall numbers out there in the world, 72% of the world's top tech corporations actually are putting their money into artificial intelligence. The only other technology that even comes close to AI is Internet of Things, that also has applications in medical, but that stands at around 46% of the global investments that are coming in. Now, if you look at the overall market size of AI, it's growing at about 26.6% every year, according to Statistica. This is the compound annual growth rate overall. And remember this number because we will compare this with the AI in neurology market in the next couple of slides. And also, the size of the market right now is about $19.9 trillion US dollars, according to International Data Corporation. So we see that actually medical science and law are regarded as two of the areas which will be heaviest in effect of artificial intelligence, right? And a lot of jobs, especially of the staff who is helping doctors, radiologists and others, will be affected by AI. And it's not that they will just go out of jobs, it's actually that people who don't practice AI might find it difficult to practice in the eras to come, because the way that things are processing, the way that things we see progressing, you see that very quickly the clinical trials market, the market of tools and many other things which are being developed around the world, it will very quickly spiral in the direction of AI, and anybody not updated in this direction may not have a very global relevance after some time. So if you look at the US digital market in neurology, I'll start with the US market, then I'll come to the global market and further on. In 2024, the number recorded, you could say the size of the market recorded was about 10.9 billion US dollars. And the annual growth rate, the compound annual growth rate for the AI in neurology market only in the US is about 20.1%. This is the compound annual growth rate. And as you've seen in the previous slide, 26.6% is overall the compound annual growth rate, and just in the US, if you look at the market growth rate for neurology, it's about 20.1%. So if it's above 20, it's usually regarded as very high, and I'll show you some market comparisons in the coming slides. Now it's global digital health in neurology market, and this is like overall market size, the international market size, and the size of the market in 2023, which was recorded, is about 32.3 billion US dollars. So it's pretty big right now, and as you can see that the market actually drives, for example, if you look at the the labels below the pie chart. So for example, patients which are directly using the devices, which are wearable devices, which they can take home, for example, and use, for example, wearable EEG, fabric embedded EEG, some things in the smart watches, even though this is not directly neurology, but maybe it is giving indirectly some predictions about neurology from the smart watch. It measures your sleep quality, your stress levels, etc., with the HPV and all that. So basically with that, the maximum market is the direct patients which are taking devices home and using them directly, but also the providers and payers, payers are the insurance companies. If you look at the international market, that's how they label it. So the payers are the insurance companies. They're also using it. They're using the health data to predict the onset of diseases. And also the healthcare providers are using a lot of devices, which means that these customers which are in the providers basically segment are hospitals which are buying devices, right? So some are patients which are directly buying stuff, then the others are providers, then are the payers, and then are others. So the total market size is about 32.3 billion US dollars in the year 2023, which has been recorded. If you look at the trend in how fast the global neurology market is growing, the fastest trend right now is in the US. The way that it is progressing, and you can see by a different categorization of colors. And of course, Pakistan is also not far behind, so we are also catching up, but the US is actually much faster than everybody. So here's a comparative statistic.
But we end in a very enthusiastic note with all the modern advances and trying to save lives and trying to make a difference. I want to give a special thanks to Dr. Seyit Öztürk, who came all the way from Turkey and shared his experience with neuromodulation. And I think each and every talk in itself was an amazing thing. Obviously, Dr. Athar Javed का तो सब सुनने के लिए बैठे ही होते हैं and he is like I just had one little comment कि X सर के नाम के आगे कभी नहीं लगना है. He's never gonna be an X of anything. And just want to thank the organizers, Dr. Babar, Dr. Naila, and Dr. Bashir Sumro, the General Secretary, and everyone else, and all my colleagues. It's always a pleasure to be here in this meeting. Thank you very much. And I think with this we conclude. Thank you.
Yes. Thank you, and I think now if there are any questions, they can have at the lunch and prayer break. The next session will start at 2 o'clock in the same hall. So 2:15, 2 o'clock. Okay.
That concludes session 2, What a Ride, from Legacies Remembered to Futures Imagined. I would like to say thank you especially to Dr. Seth Osturk, Professor Atar Javed, and Professor Yasser Ayaz.
For shield distribution, I would like to call Dr. Manzoor Lakher, a professor of neurology and HOD of Neurology Department in Liaquat University of Medical Sciences, Jamshoro.
Please be seated for the shield distribution. The lunch will start after this. Can we please have Dr. Danish Bhatti to receive the shield, please?
I would like to call Dr. Sad Osterk to please come on the stage to get the shield.
Can we please have Professor Atar Javed? Yes, it is.
Now I would request Professor Yasser Ayaz to please come on the stage.
The moderator of this session, Dr. Mansoor, please collect your shield. Can we please have Dr. Fozia? Yes. Professor Dr. Khurram Haq. Dr. Nader Zafar. Dr. Nader, could you please present a shield to Dr. Manzoor as well? Lunch. 2:15? It's now time for lunch. Please proceed back to the hall at 2:15 while we start our third session then. Thank you so much. On the right of
Thank you. Charge
प्रोफेसर ऑफ न्यूरोलॉजी एट सियालकोट एंड हाँ बस ठीक है उसको कहते हैं बताना कोई बात वो अपना मरीज को टेस्ट को भी दिखा दे पता नहीं वो कौन सा मरीज है वो गरीब मरीज है मेरा कल उसको हमने देखा है सर वो मेरा भी 1 घंटा उसने उधर लगाया अब वो बेचारा खाना खा रहा था और खाने के बीच में
चले तो इसलिए इनका ये रहने दो ठीक है
यार बस मैं खा रहा
और उसके तो ये नहीं है आलम इब्राहिम सिद्दीकी साहब नहीं है उनकी
प्रोफेसर मंजूर प्रोफेसर मंजूर लाखे वो उसके पास था वो जो प्रोफेसर मंजूर लाखे प्रोफेसर ऑफ न्यूरोलॉजी एंड हेड ऑफ न्यूरोलॉजी एट लियाकत यूनिवर्सिटी ऑफ मेडिकल साइंसेज जामशोर
Assalamu alaikum. So welcome back, everyone. Hope the lunch was energizing, though there is a fair warning that the science this afternoon may be heavier than your plates. So before the circulation goes to your gut and starts setting in, let us proceed with our third session and the last session for today. So this session will be moderated by Dr. Shoaib Luqman. He is Assistant Professor and Head of Neurology Department at Quaid-e-Azam Medical University, Bahawalpur, and he is also the General Secretary of Pakistan Stroke Society. This session will be governed by our three expert panelists. Professor Adnan Khan, he is Professor of Neurology and former Head of Department at Lady Reading Hospital. Okay, I think Professor Adnan, okay, he's at the door, right? Professor Manzoor Lakher, he is Professor of Neurology and Head of Department of Neurology at Liaquat University Medical Sciences, Jamshoro. Dr. Sara Khan, she is Professor and Head of Neurology and Neuromuscular Medicine at Aga Khan University, Karachi. Dr. Shoaib, kindly take over. Thank you.
Thank you, Waleed. We will be starting this session with the talk by Dr. Jawad Hassan, who is Professor of Medical Genetics at Shifa Tamir Millet University and Director of Medical Genetics at Shifa International Hospital, and he is also former Chair of Biomedical Sciences at NAMS, Pakistan. Professor Jawad Hassan, please.
Oh, okay. Thank you. Thank you. So I was just repeating, thank you everyone who came back after lunch. It's a good sign, so many people there. So thank you very much to organizers for inviting me to this talk and to our worthy panel. I'll be talking about the genetic diagnosis in the era of precision medicine. So because I'm not a neurologist, so maybe most of you don't know me, so I would try to just give this glimpse. I did my PhD from Quaid-e-Azam University, Islamabad, and then I work in different medical universities preferably. And then my research group is actually working on the neurogenetic diseases, their gene identification, mutation detection, and the things like this. And at the moment, I'm working as a medical geneticist in Shifa International Hospital, Islamabad, and also as a professor in Biosciences Department in Shifa Tamir Millet University. So for today, we'll try an overview of the rare disease and why we do the genetic testing, how we identify the genes, some of the research glimpse from our group, and then can we have some therapeutic approaches for these diseases, and then what we can conclude. So just to start, if you just see this slide, the rare disease as a global information, you see that this is the total baseline birth prevalence for rare single gene diseases by the World Health Organization regions. And we have one thing here that the marriages within the families is there in these regions. Consanguinity is associated with recessive disease, and that's a global phenomenon. So why these mutations, they occur, we know that the DNA polymerase is one of the reasons, and we say that the error is polymerase because it makes the errors during the replication process, so these things, they happen in routine. And if you see this slide, जो late onset वाली diseases हैं, they are not included here. It's only the birth line. So you can see that we have a rate 1 into per 1,000 births here for EMR, East Mediterranean, in Africa, Southeast Asian, and other regions. And here we are with the neurological diseases, the global perspective. This is an article published in the Lancet Neurology. I took this picture from there, and we have seen that the stroke is there. If we adjust on the left side in A, that is the disability adjusted life years, and the B, we have the deaths on the right side. So stroke is there, and then we have the migraine, and somewhere we have the epilepsy in the green. So this is what we have with the neurological diseases, and for many, many of them, we have a genetic cause behind. So what is the rationale of the genetic testing in neurological disorders? And we will talk about the Pakistani scenario especially. We have large family sizes here in Pakistan, and we usually tend to marry within the families. So, of course, we have the more numbers with us with the recessive disease, and there is a socioeconomic burden on the affected families and overall in the country, because for most of these diseases, कोई हमारे पास बहुत अच्छी cure available नहीं है. We just do the management. And for specifically, if we come to the neuro, that they are diverse and heterogeneous diseases in terms of the symptoms. We say that the spastic paraplegias, there may be over 80 subtypes. You have ataxia, spinocerebellar ataxia, there will be over 40 subtypes. So with so many overlapping symptoms, it's not easy to identify. And then onset is an issue, specifically if we talk about the genetics and the prevention, because if the disease is with the late onset, and maybe it starts at the 18 years age or 20 years of age, then we may have 3 or 4 or 5 kids in the family until the first one reaches the age of 20, which is affected. And there might be 2 or 3 other affected, but unless we detect the first one, then the problem is there, and the issue is there because 2 or 3 people, they are affected in the family. So these issues are there with neurogenetic diseases. And if we do this genetic testing as early as possible in the affected and in the carriers especially, then we may prevent many, many things, and especially we can stop or we can minimize the number of affected individuals in the family, and we can better manage the disease, especially in case of epilepsy. If you can see, we have the mutations, we have the genes. If they are mutated, then the selection of the drug is related to that particular gene of mutation. And of course, if we have the mutation, then it is helpful for the better future decisions. We can do the screening before the marriage, then we can do the screening during the pregnancy through NIPT or CVS procedures. They are available now, but only if we have the mutation in the family. If we are able to detect it, only then we can do the screening in the family. So now how we identify the disease genes, especially in the start, we enroll in the clinic. And if, of course, the clinical evaluation, and then we do the genetic testing if it is required and if it is especially recommended in that particular patient. And then we have 2 or 3 or 4 ways to do the things. Either we do the whole exome sequencing. I will just let the detail what exactly it is. And then we can do the specific group of genes, especially 30, 40 genes for a particular disease, the gene panel. In any case, if we found something pathogenic or likely pathogenic, then we do the clinical correlation. And then if there's a new gene, of course, in the research area, we have to do the animal studies, we have to do lots of bioinformatics. And if it is a known gene, then of course we do the family counseling, then the screening in the family, and then we refer back to the clinician so that they can do a better clinical management. So something is interesting here. We know that in human genome, it's about 5% there are genes in the genome. 5% of the region of human genome are genes. 95%, we called it the junk DNA, and we assume that this 95% contains certain regions that are involved in the regulation of the gene expression. That's all what we know so far. And this 5% genic region, it contains exons and introns and the untranslated regions, UTRs, and all gene-associated area. So when we do the whole exome sequencing in the clinic, and if we outside the clinic in the lab, of course, it's about 1% of the genome, because we only check the exons and the exon-intron boundaries and some of the promoter regions. That's it. So this is one of the reasons that the success rate for a solo exome sequencing, it varies between 35% to 50%. That is why, because we are only hitting into the 1% of the human genome, not more than it. And another information is that we have about 20,000 protein coding genes in the human genome. About 7,800 a month before, we know their disease association. We know if there's a mutated, this gene, the mutation caused that particular disease. For the rest of 12,000, we didn't know this thing. So many things are still they are hidden from us, and the research is required. So what we do in our research group, just a glimpse in the past almost 10, 12 years after my PhD, and one of my collaborators, Professor Aslan Ahmad, is here. We did about 76 families with different inherited neurological disorders, and they contain the insensitivity to pain, epilepsy, primary microcephaly, ALS, cone rod dystrophies, hearing impairment, which is sensory neural, and some novel syndromes. And we are able to find the mutation pathogenic variant in about 48 families so far. Rest, still we are in progress. We are unable to find the things. I will just show you one or two of them, how we proceed. This is what our methodology. If we do the research, classically we do the homozygosity mapping. Nowadays, it's really not done. As such, we directly do the whole exome sequencing or the whole genome sequencing. And then specifically, lots of bioinformatics is required. In silico analysis is there, the prediction and the protein modeling is there. And then if we go to some animal studies, of course, we need a very good collaboration to some lab outside Pakistan. Inside Pakistan, we don't have we don't have these facilities with us. So the four families A to D, they have congenital insensitivity to pain. What we see, they are the pedigrees. You can see A, B, C, and D. These black, they are affected people, and this is died. This is consanguineous marriage. And here you can see that they belong to same area, the same region, although they are not blood relations there, but they belong to same area, they speak same language. So you can assume the recessive disease is there. And here they are the clinical assessments. Of course, this is problem. If you go to a far-flung area, the exact neurological clinical assessment is not quite easy to do. And this is one of the dilemmas in the families. They are published from Pakistan, that clinically we are not strong in the field. Of course, if you come to Shifa Hospital, we are strong, but in the field, we are not that much strong. So they were congenital insensitivity to pain, absence to response of pain all over the body. They were intelligence was okay, except one in the family D. There was steering blood pressure, okay, except the one, and then unable to distinguish sharp, dull, and hot, cold stimuli. This was the overall symptoms. What we do is we do the homozygosity mapping here, and we find the same homozygous region on the SNP based homozygosity mapper in all the four families on chromosome 2. And what exactly we find that there is a gene inside it that is sodium channel 9A, which is already available there, and we know this is the candidate gene. So we sequence it, and we found this deletion here in the SCN9A gene in all these four families, and the mutation was segregated, and the families affected were have these deletion, and the normal unaffected people, they don't have this deletion. So it segregated with it. So it was our conclusion of the four families, just to show you that this is how we do the research in the field. And here we are with a manuscript in the clinical genetics. And then we do the gene panel sequencing for our patients at Shifa International Hospital and my previous job place at NAMS. And this is how we do that. This is the procedure. I don't go into the detail. Usually we do in the lab these things. And what we were able to identify 5 families with some sort of epilepsy. We do the epilepsy panel from a company in the USA, and we actually find 5 pathogenic variants in the 5 different families, and we actually able to publish it here. And then again, we have this recent publication in this GLA gene with the Fabry's disease. We identify at Shifa International Hospital, and we are trying to get some enzyme replacement therapy, Fabrazyme, for this patient. And here we have this mutation in the cadasal, which is quite not so common here, and we actually find this first patient in Pakistan with this mutation available, and we identify this one. Then, just to show you that if we have the mutation, if we are able to get the mutation, what would be the benefit? So in case of epilepsy especially, you can see that if we have a mutation in these sodium channels, we need to avoid certain drugs, we need to have certain drugs. So the selection of the drug in case of epilepsy, if you have the mutation, it will aid you for better management of the patient. So going towards the end, we have the therapeutic approaches available for these neurogenetic diseases, and they are FDA-approved drugs. I took from this link, and they are the drugs which are for the gene therapeutic approaches through the viral vectors or through some other approaches, enzyme replacement therapies. They are for ADC deficiency, for DMD, for metachromatic leukodystrophy, inherited retinal disease, cerebral adrenoleukodystrophy, spinal muscular atrophy. Then we have this Fabrazyme for the Fabry's disease and a specialized form as well. So they are available for neurogenetic diseases so far. So if you go to end, I will conclude that there is a need to create awareness in the clinicians and the general public about the genetic disease, the origin of the genetics in the symptoms. And then we need an effective collaboration between the clinicians and the people working in the lab or people working on the genetic disease so that we can have better management for the patient. And towards the end, I think we should have a genetic testing lab in Pakistan, because all of these testing, all of these NGS, we send the sample abroad and we have the results with us, but it is required. If we have this lab in Pakistan, then it will solve many, many problems. So the acknowledgements to the families, to HEC for many grants, to our group, to Professor Aslan and Dr. Amjad from NUS, Dr. Saqib from UHS Lahore. We have our research groups, and to our students who actually work for this one. Thank you very much from my side.
Thank you, Dr. Jawad. We can take any questions from the audience, if we have any questions. Yeah, sure, you can.
Thank you, Dr. Jawad, for this excellent talk. Question for you. Now, as we are recognizing genetic syndromes much more, a lot of our initial diagnostic workup goes towards genetic testing rather than going through, for example, nerve or muscle biopsy and doing all the extensive testing. That saves a lot of money going directly to genetic testing. Recently, of late, I've noticed that our geneticists are going directly to whole exome sequencing rather than doing the individual panels because it seems to be economically similar now. Is that the case, and is that what our investigations will change to our line of investigations?
I think I should agree with this point. Yes, there are two issues. If you go to whole exome sequencing, we may find a mutation for the disease in which we are observing. We are observing the symptom. Maybe the patient is a 3 years old or a 5 years old guy. But the whole exome sequencing may also identify the Alzheimer's variant in it, which may be present later in the life. So here is the problem. But on the other side, yes, we should go for it. Why? Because if that patient get married, it may have the kids which are affected. So if we identify the mutation, which is for a disease which may come later in the life, but you can stop moving it into the next generation. So here is the argument for it. And yes, if you do the gene panel, maybe from NVT in the USA that we are doing previously, it costs about 1,60,000. And we are just ordering the whole exome sequencing from BGI China, just about 1,75,000. So I think we should go for the whole exome rather than panel. One point more is that at times we have so many overlapping symptoms and we are not sure exactly what the disease is. So if we go to one panel, we may miss the mutation which is there. So better to go for whole exome. That's the point.
Professor Aslan has a question.
Further to your answer, Sara, ये होल एग्जोम की तरफ हम भी मूव हो गए हैं. हमारी भी फर्स्ट प्रेफरेंस, अभी मैं नादिर को भी बता रहा था कि वी प्रेफर्ड, क्योंकि जो पैनल्स हैं, पैनल्स में मिस समथिंग्स. हमारे अभी तक जो है वो जो पाकिस्तान से जो जेनेटिक वर्क है इतना ज़्यादा हुआ नहीं है, और जो नॉन म्यूटेशंस हैं वो भी ज़्यादातर वेस्टर्न डेटा की नॉन म्यूटेशंस हैं. सो वी विल, इफ़ वी डोंट डू होल एग्जोम and we do a panel, is more likely we will miss things, क्योंकि only those that are characterized वो उसको बता देंगे ये पॉजिटिव है. और जबकि होल एग्जोम में एक जो डिसएडवांटेज होती है, एक VUS वाली होती है कि वेरिएंस ऑफ अननोन सिग्निफिकेंस निकल आती है, आपको पता नहीं वो क्या है. और रेयर डिजीज़ नेटवर्क जो है वो हर 6 months के बाद अपना अपडेट करती है. सो अगर वो VUS भी निकल आती है एट दिस पॉइंट इन टाइम, मे बी 2 years लेटर दे विल कैरेक्टराइज maybe a disease to that.
And उसमें फिर phenotypic correlation becomes very important. You have to go back, जो gene आया है, even if it's a VUS, to properly examine the patient in the context of that VUS and see that if it's an actual cause.
बिल्कुल हमारे पास होता है, हमें ये phenotype genotype mismatch होता है, and we are stuck.
Yeah.
Thank you. Ji, please.
Thank you for your presentation. My question is regarding again the gene panel, targeted panel. So if we are considering a neuromuscular disorder and we get 2 genes which are not actually phenotypically correlating, for example, we were suspecting SMA type 3 variant kind of a form, but the gene that came was of a congenital myopathy or a congenital myasthenic syndrome. Does come in the neuromuscular disorder but doesn't fit in with the clinical picture. So should we always, again the question is again the same, that should we always go for a WES first, or we can somewhat reliably go for a neuromuscular panel only?
ये देखें, इसमें भी यही बात है. अगर आप मरीज से कहेंगे वी गो फॉर अ पैनल, उसने 1,60,000 रुपये लगा दिए, उसमें हमारे पास अगर एक VUS आया है, yes we see the VUS, we clinically correlate, we try to segregate variant in the family कि वो हमारे जो inherited जो मॉडल है उसके साथ मैच हो रहा है कि नहीं. बट अगर हमने होल एग्जोम नहीं किया तो हम उसको डेफिनेटिव नहीं अपना वो हल बना सकते. वी हैव टू गो फॉर होल एग्जोम. सो उससे ज़्यादा अच्छा है कि होल एग्जोम पे चले जाएं, अपने स्नैरियो को देखते हुए 2 दफ़ा लोगों के पैसे ना लगवाएं. That's a better point.
I see that we have a few questions from the audience, but we are already running very late, and probably Dr. Jawad will be here, and you can discuss with him later on. The next talk is breakthrough in neuropathic pain management. The next talk is breakthrough in neuropathic pain management, and I invite Professor Dr. Bashir Somro for this. Professor Bashir Somro is the chair of Neurology at Ziauddin Medical University, Karachi, and he is also the General Secretary of Pakistan Society of Neurology. Professor Bashir Somro.
Regarding my talk, I would like to discuss the current management of pain management in patients who are coming to the tertiary care or in primary care or in secondary care. You see, pain and fever is a very common condition which everyone faces in life. Either they experience the pain or they can manage the pain. So my disclosures are nothing to disclose about, and there is no conflict of interest in this presentation. I was invited by Dr. Babar to give some innovative pain management treatment. So outline of presentation is neuropathic pain, its clinical manifestation, the diagnosis, management and future advancement which are taking place in world over for pain management. So pain is the priority for both, for as a physician as well as for the patient as well as a caregiver. So whenever there is a pain experience, somebody who is pain, it is a priority for everyone. So an unpleasant sensory and emotional experience which is associated with the actual or potential tissue damage which can lead to the pain. So pain can be classified on duration. It can be in acute pain, it can be chronic, or it can be acute on chronic pain. So by intensity, if you define it, the mild, moderate and severe, in our clinical practices, we use a cartoon which is showing you the mild, moderate and severe pain scale. We always place in our clinics to define the pain by the patient, by the family and the caregiver. So physiologically, the pain can be nociceptive, it can be neuropathic pain, it can be a psychological pain. We see a lot of patients who come with the headache, neck pain and back pain. Actually, they have underlying psychological issues, like you see commonly depression and anxiety and some mixed picture of bipolar disorders. They presented with the pain in any region of the body. So this is a very good scale which I used to in my clinic, and it's very difficult to assess how pain intensity it is, but this cartoon makes very easy. So this pain can be 0, no pain, it can be mild, in between the 1 and 2, it can be moderate, it can be severe, it can be very severe, and it can be worse. This cartoon helped me when I was investigating the patients of fibromyalgia, so I used this scale in my clinic, and we wrote some local studies of using memantine in fibromyalgias, and these papers have been published in the Pakistan Journal of Neurology. So pain perception it starts from the stimulus from the periphery, where it can, here, this is an stimulus where receptors, they transmit transmission to the posterior ganglion and then they enter neuron. So first order this is, then this is a second order neuron. The thalamus perceives here, and they use, it is assessed in the cortical area of the brain. This is the same which I was describing, afferent. This goes first order, this second order, it perceived in the thalamus, and then thalamus sends sensation to the cortex also. So neuropathic pain, as per International Association of Study of Pain, is caused by lesion or the diseases of the somatosensory nervous system. It represents a significant healthcare challenging. This is the Lancet 2025. They reported the challenge is affecting 6.9 to 10% of the general population. So mechanism of neuropathic pain is peripheral mechanism, or it can be a central mechanism. So it can be primary peripheral pain, it can be a secondary pain. And there are differentiation between the nociceptive pain and the neuropathic pain. Nociceptive pain pathology is nerve stimulation from injury, tissue injury, and the neuropathic is pain from the direct nerve injury. While description is nociceptives are dull, aching and cramping pain, which can be throbbing and pressure-like, and the neuropathic can be bumping, shooting, tingling, stabbing, with wise-like and electrical shock-like pain. So we can differentiate between the nociceptive and neuropathic. The examples of nociceptives are bone mates, visceral angina pain, and the neuropathic can be diabetic neuropathy, which is very commonly prevalent in the society, and the brachial plexus pain, which can be presenting by the unilateral arm or a leg. Sometimes leg pains are the lumbosacral plexus involvement. So pharmacological therapies are commonly used by NSAIDs and anticonvulsant medications. And this is again nociceptive causes and features. The consequence of pain is very important to consider. It affects your quality of life, it affects your physical activity, it affects your emotional well-being and economic burden on the individual as well as on the society as well as the family, which is affected by the pain. So physical activity can limit because of the pain of the lumbosacral area. The patient presenting with their lumbosacral pain area, they have a lesser physical activity. The emotional well-being, अगर एक घर में एक ख़ानदान में एक खातून है और सडनली कोई पेन डेवलप करती हैं तो उनकी सारी ज़िंदगी में जो बाकी लोग अटैच्ड हैं वो सारे डिस्टर्ब होते हैं, तो दे कैन हैव अ इमोशनल वेल-बीइंग काफ़ी अफेक्ट होती है एज अ पेन की वजह से पेशेंट की एज वेल एज विद द फैमिली. So economic burden, why economic burden is important to consider? Because pain management की जो दवाएं बहुत महंगी भी हैं और cost effective भी हैं. So as a physician we should consider the cost of the patient whenever we are prescribing any medication to the patient. So I described earlier the peripheral and the central causes of the pain, and the etiology of the peripheral pain is very common, which is entrapment neuropathies. As a neurologist, as a neurosurgeon, as an orthopedic surgeon, we see a lot of entrapment neuropathies in our clinics. Diabetic polyneuropathy is very common, and the chemotherapy induced pain are very difficult to treat and sometimes very difficult to manage. And the post-herpetic neuralgia is very common, and the radicular pain at the area of lumbosacral area or the neck area, and the post-surgical chronic pain management is sometimes difficult. This is again a cause of peripheral causes. The post-stroke central pain are very common. Multiple sclerosis, central nervous system disease, which can lead to central neuropathic pains. Sometimes trigeminal neuralgias, very difficult to treat and very trouble creating in clinics. Patients, they experience neuropathic pain, and some spinal cord related injuries can lead to the central causes of the neuropathic pain. What are the features? Features are very common. In neurology, we see burning, pins and needles, paresthesias, tingling, stabbing, electric shock like crawling, allodynia, hyperalgesia in advanced cases. So clinical manifestation of neuropathic pain, allodynia is very common. We see a lot of patients in our clinics who they present with the non-painful stimuli, they feel allodynia. Patient आके अक्सर कहते हैं डॉक्टर साहब ठंडा पानी सर पे गिरता है तो बहुत एहसास होता है कि बहुत पेनफुल होता है और कभी कभार कंगा करना बहुत मुश्किल हो जाता है पेन की वजह से. And hyperalgesias, hyposthesias, paresthesia, tingling, and sometimes the people can present to you with pain, functional impairment, especially the sleep, mood and quality of life have disturbances in the painful conditions. So management of neuropathic pain we should consider as a holistic approach. These can be, number A is a non-medical treatment, which is very important to educate the family as well as the patient. Lifestyle modification, psychological approaches, physical therapy, which is now commonly available everywhere in the centers who are catering the, and the TENS therapy is very simple and better way to be prescribed to the patient at home also. and complementary approaches are very important. So medical treatment is medication, interventional procedures and surgical options are important. Sometimes we refer patient to the surgical clinics to relieve the entrapment neuropathy, especially that carpal tunnel syndromes. So always consider non-medical, medical treatment and the medications which we can use. The newer therapies are emerging. Astrocyte-based therapy is emerging. Neuroimmune modulation is and gene and straight cell therapies are emerging. So non-medical treatment, consider always psychological therapies, interact with the patient family and always ask them to have a physical therapy and mind body practices like yoga, neuromodulation. Sometimes it releases what? Endogenous neuropeptides are released which activate the neural activity and decrease the inflammatory markers and they increase the muscle strength. So always consider physical therapy, neuromodulation, psychological therapies, especially the interaction with the family and the patients is important. So this is a simple TENS therapy which is available everywhere in Pakistan and every city can have a TENS use in clinic as well as at home you can use this neuropathy. And this is a very simple device. It costs about 6,000 to 7,000 and it is electrodes are placed and lead wires are connected to the stimulator. The complementary approaches are radio frequency ablation. This is commonly used for chronic pain conditions like rheumatoid arthritis, trigeminal neuralgias, and lumbar spinal pains. This is targeting the precise and pain reliefs. We used to refer those patients who are refractory to the medications, who are very refractory to the nerve block, so we used them to the radio ablation. I have a few cases which have been resistant to the refractory to that medications as well as the other measures of trigeminal neuralgia, and we asked them radio ablation from Singapore. They responded very well to the patient. And the low risk factors like minimal procedures like. So coming back to the medical management of neuropathic, this is recommended first line medication which has been published a guideline June 2025. They recommend 2-alpha legend gabapentinoids, and we know gabapentinoids are available in Pakistan in 3 forms, and serotonin, SNRIs, tricyclics, very simple medication which is available, but tricyclic has a side effects. So always consider in young patients, in females, especially low doses, start with low doses, but this is a first line treatment you can consider. And the recommended second line therapies are capsaicin patches, which are available, but in Pakistan they can be imported 8%, and some creams are available which are locally manufactured. The recommended third line medication is by Lancet 2025 June. Botulinum toxin have a capacity to relieve the pain, and repeatedly transmagnetic stimulation targeting the primary motor cortex, and cannabinoid CBD oil which is available but is very cost effective and costly medication. In the end you can use as a third line. Consider first line medication, second line and third line. So gabapentinoids are usually we go through the gabapentin, pregabalin and mirogabalin which is available now. The targeted are 2-alpha legend subunits of voltage and gated calcium channels, and they are indicated in diabetic neuropathy, post-herpetic neuralgia and spinal cord injury. The side effects are very common, sedation and dizziness. While in pregabalin, there are one thing is important to prescribe whenever you prescribe to the patient, they are addictive medications. So do not prescribe without prescription to the patient on high doses, because it is addictive and it is a habit forming medication. So now the luxury of mirogabalin, which is non-FDA approved, but it has been used in Japanese and Asian population. It can be used in 10 milligram and 30 milligram. It has a greater binding affinity for alpha 2-1A and alpha 2A voltage gated calcium gated channels. The mechanism of action is important to understand. Here I will CNS, I will target CNS side effects. CNS side effects have gabapentin, pregabalin have a higher affinity for the CNS side effects, while mirogabalin has a low, moderate, improved tolerability and a lesser side effect in patients who are using the mirogabalin. So whenever you prescribe gabapentinoids, the first choice is a gabapentin, which is available in, and the tolerance at the 400 milligram, people become intolerant to this medication. I have used up to it gives you the side effects. And while in pregabalin, we can start with the low dosage and it can be effective 100 milligram BID, but it is a self-addictive medication, so try to avoid it. And CNS indications. So other indications of gabapentin is epilepsy and post-herpetic neuralgias, while pregabalin has a generalized anxiety disorders, it can be used. In FDA has not approved the mirogabalin, but it has been used in the patients who are Japanese population and some Asian countries. So it can be used in neuropathic pain and some post-herpetic neuralgias. While first line other drugs like tricyclic antidepressant, it can be started with 25 to 150 milligram per day. The mechanism is the same, serotonin and non-epinephrine reuptake. It leads to adverse effect like dry mouth, constipation, blurred vision, and some addictive effect, and it can have a side effect in the heart. It can lead to the heart block also. While duloxetine and venlafaxine is available, which are very effective, but start with low doses, and it can be used in diabetic neuropathy patients who are non-responder to the first line medications. Second line is topical agents. The topical agents, along with the complementary approach, lifestyle modification, improve the sleep and physical activity, and there's some newer opioid-like medications are also available. I will discuss this. And this botulinum toxin, which is again a third line medication, and some NMDA and cannabidiol can be used. So this is a non-opioid analgesic which is available in Pakistan, suzetrigine. It inhibits the voltage-gated calcium channels, and it reduces the pain signals and dorsal root ganglion and sensory neurons, 99% protein bound. For moderate to severe pain without risk addition. Some common side effects are muscle spasms, increased blood level of creatinine, phosphokinase, and rash. So it is available. I was reviewing the literature. There is one study from Multan they have conducted on few patients, and it has been published in patients with a non-opioid pain and medication. So what are the interventional procedures for neuropathic pain? The non-invasive and procedural treatment of neuropathic pain is for complex or refractory cases. They target peripheral, central, and psychosocial mechanisms involved in the chronic neuropathic pain. The procedural treatment for neuropathic pain are spinal cord stimulation, and it delivers electrical impulses to the dorsal column of the spinal cord for patients with complex regional pain syndrome and failed back surgery syndrome and peripheral neuropathy also. The surgical options are decompression of the entrapment neuropathy, then spinal neuropathies, and intrathecal delivery of the drug, especially those who have a chronic neuropathic pain. Newer treatment options are astrocyte-based therapies. It exerts analgesic effect by inhibiting the astrocyte activation and the release of pro-inflammatory cytokines. So astrocyte-based therapies are used in neurodegeneration and neuroprotection in neurological disorders. And the astrocyte is star-shaped glial cell most abundant in the CNS. They key regulate the neuronal health and target the stroke, ALS, Parkinson's disease, Alzheimer's disease, epilepsy, and spinal cord. The key function of astrocyte is a neurotransmission clearance, maintain ionic balance, blood-brain barrier integrity, neuropathic support, and modulation of the synaptic. So it can be used in cell replacement and reprogramming, and the metabolic in the and gene and drug delivery. The gene therapies, which is again is last slide. Target sensory neurons in the peripheral nervous system, including the dorsal root ganglion and trigeminal neuron. So this is a summary of my presentation. In this triangle, you can see the first line, second line, third line, procedural treatments, and future direction. Thank you very much. These are my references which I used currently in my presentations. Thank you very much.
Thank you very much, sir. We have time for just one question if somebody has a question. Thank you, sir. Oh, I see there is one question.
Sir, Atar Javed.
Atar Javed, sir.
Sir को mic दे दें.
Thank you very much. Very nice presentation.
Thank
Just
you,
one question, that magnetic stimulation of primary motor cortex, how would it relieve the sensory pain which is expected to be involving the sensory pathways?
So ultimately, the cortex is the one which involves in the analysis of the pain. The current is recommended, but you see, there is no experimental studies in Pakistan, so I have no idea what about, but my understanding it suppresses the cortical activity in the brain, though perception of the pain is reduced. This was beyond my knowledge.
Thank you, sir. Thank you, Bashir Samra sir. Thank you, sir. Our next talk is by Professor Dr. Qasim Bashir, who is Head of Neurology and at Services Institute of Medical Sciences. He is also Chair of Director of Neuroendovascular Surgery at Punjab Institute of Neurosciences and Focal Person Provincial Stroke Management Center at Lahore. He will be talking about tenecteplase better than alteplase in our setting. Sir.
Assalamu alaikum everyone. First of all, thank you, special thanks to the organizers for giving me the opportunity to come and present on tenecteplase. So, as we know, like after 30 years, we have a new drug outside TPA. So I have
from some iCloud data isn't syncing.
Sorry. So I have no conflict of interest. So just to refresh some memory, 1996, FDA approved the first drug, tenecteplase, also called alteplase. It was initially approved for up to 3 hours, and then subsequent society recommendations came about, and they extended 1.5 hours from 3 to 4.5 hours in sub-select patient population. And then you also know that the dose for this medication was 0.9 milligrams with the maximum 90. With 1 hour of infusion, the first bolus goes over a minute, and then the remaining over an hour. But over the years, what we found was that tenecteplase, alteplase, had a recanalization rate of up to 35, 40%, different studies, different results, but on average, I would say like around 40% recanalization rates for alteplase. When the research is done and they're looking for something very effective, either in the form of IV thrombolysis or thrombectomy. So these are some of the things that are looked at. First of all, is that treatment going to be safe? Second, how much is going to be the reperfusion if you're going to be using endovascular therapies? Yes, you're going to be using certain grades like Tiki grades and expanded Tiki grades. What is going to be the impact on the disability? 90 days modified Rankin score, is there going to be a change in at least one number? And overall functional outcome in 90 days. If that treatment is going to be used with or without thrombectomy or endovascular therapies, again, the judgment points are basically safety and the reperfusion. Whether the treatment is going to be safe, you're adding IV thrombolysis with endovascular, or you're doing just endovascular. How you're going to calculate the reperfusions, and what is going to be the time to recanalize, because if you can give an IV thrombolytic, is it going to help in the recanalization and hence reduce the time to recanalization? So from 1996 to 2025, it's not that once the TPA came out, studies were not being done on other medications. There were so many trials that came out and they were found insignificant, went away. But then this is a timeline which I wanted to show you. This first safety dose actually for tenecteplase was done in 2005. And subsequently thereafter, CT perfusion studies came in. They were looking at trying to filter more ideal patients with CT perfusion, calculating the dose of the patient, dose of the tenecteplase, whether 0.1 is effective versus 0.25 versus 0.4 milligrams per kilogram, and then also the bridging therapy. So subsequently, all these trials started to come into place. And you can see on the timeline that the major trials, the data, came up till 2022 and 2023. And there are so many others which I'm going to mention at the end, just for the sake of the references, which are going forward in regards to the tenecteplase. So based on all of these trials, the first recommendation that came out was in 2019 by American Heart Association and American Stroke Association, that 0.25 can be a reasonable option over alteplase as a bridging therapy. They did not say that this is the only option, but they gave it, phrased it as a reasonable option. 4 years later, the European Stroke Organization recommended 0.25 based on all the studies that I just recently highlighted, and recommended that, they actually recommended that tenecteplase can be used as a first-line IV thrombolytic. So when it comes to the tenecteplase, the organizations looking at the trials, the FDA looking at the trials, I think the most important one that has been highlighted is the ACT trial that came out from Canada. So it was done in 2022. Basically, this trial proved that TNK is not inferior to TPA at 0.25 milligrams per kilogram doses. So this was a very important trial, which 30 years later led the FDA to approve tenecteplase in February of 2025. So 30 years later, we now have a second drug outside TPA approved by the FDA with the same indication, 0 to 4.5 hours. And this is the dosing chart, like 0.25 milligram per kilogram with the maximum 25, and you can see the dosing chart. I'm going to show you a video at the end, the preparation. So it's made in a 5 cc syringe, so everything is calculated based on the weight, and has a lot of advantages that we're going to talk about. Now, a quick word on the manufacturing. So I have just like a lot of interest in the history and who's manufacturing and why it took so many years, even though the WHO and so many other organizations have a lot of these rules and regulations that you can only hold the patent up to 10 years. Why only TPA was being manufactured just by one manufacturer for the globe and one for the US? So anyway, so that's a little bit more of a political history, but anyway, so from 1996 till 2022, the whole world was divided outside the USA just for the PGRs. Only the US was allowed to manufacture TPA by the BI, and the company that manufactured over there was Genentech, and the rest of the world was dealt by Germany, Boehringer. But in 2022, China entered with tenecteplase. So I couldn't pronounce the name of the company, so I've just written over there, Ganzabo, something common. But it's a slightly different processing as compared to the tenecteplase that we have now gotten in Pakistan and the rest of the world. But the only difference is the processing. The rest of the structure, the molecular structure, everything remains the same. But this is what they are using as of 2022 and have produced a lot of major studies, which one of them I'm going to mention. So what is different about tenecteplase than TPA? Basically, tenecteplase is TPA, but it's a mutant genetically modified molecule of the TPA. Only 3 amino acids have been changed, and you can see with that change, what happened was that the plasma half-life was more as compared to TPA. Fibrin specificity and the plasminogen activator inhibitor effect of the tenecteplase was far superior than TPA. So 3 molecular amino acid change, 3 major changes coming in the functionality of the drug led to having better clot dissolving capability, at least by 50%, with a 13.5 lower doses as compared to the TPA, just because it had an 80% more efficacy on blocking the plasminogen activator inhibition receptor. And also, because of the extended plasma time compared to the TPA, it took less than a third of the time required by the TPA to dissolve at least 50% of the clot volume. So a meta-analysis of the test trial in the Australian TNK Extend IA trials actually showed that it had 2-fold higher outcomes, good outcomes with modified Rankin score rated between 0 to 2 at 3 months, and 3-4 higher rates of recanalization compared to TPA. Another pooled analysis of a test trial in Australian TNK trial had a larger patient population, and they actually showed that the complete vessel occlusion, 24 hours, NIH improvement, clinical improvement, modified Rankin score improvement in 90 days was better in the TNK groups as compared to the ones that underwent TPA. Another important thing that came out as a subgroup analysis of the same pooled analysis trial of the test and the Australian TNK is this one, where they showed that if you have another better patient population selected on CT perfusion with the baseline ischemic core of less than 70 cc's, target mismatch ratio, and the volumes, if this particular set of patient is given this drug and the therapies, has even a better outcome as compared to the ones that they highlighted before. So again, a point that goes in patient selection. So one question should always come in mind is, why just a bolus as compared to 1-hour infusion of TPA? So the answer lies in the plasma half-life, and the answer lies in the slow plasma clearance. So since it has 20-24 minutes half-life, so you only need to give it as a bolus over 5 to 10 seconds as compared to giving an extended 1-hour infusion of the TPA. Some animal studies have also been carried out with TNK looking at surgical sites, because sometimes we do come across such scenarios where patients have undergone surgeries or minor surgeries, dermatology procedures and those type of things, and then the question comes, give TPA, tenecteplase, or don't give any of the 2 drugs. So one such animal study I wanted to highlight, this thing showed that even if you have a procedure where there's a deep surgical cut, patients who received TNK bled 35% less as compared to the TPA. So something just to take home, but not at this point I would say that it's a strong recommendation, but something gives more of a sense of security. Now, does age matter? Because when the time window for TPA was extended from 3 to 4.5 hours, age was one of the factors. So in this case, a trial, Norwegian trial, the NORD test, looked at their 273 patients, all of them 80 years of age or more. Again, everyone received tenecteplase within 4.5 hours. Symptomatic hemorrhage, not significantly different between the two groups, and the functional outcomes, again, found to be better in the group which was older. So this is just one trial that has looked at the age. There is another one which looked at the age as a subsection of the pooled trial of the Extend IA, and they looked at the dose 0.25 versus 0.4 milligrams associated with improved 90 days outcome in 137 patients more than 80 years of age. But again, this was a small set of patients that they looked at after the main trial was published. So again, whether to give tenecteplase for patients who have minor stroke. So when we are talking about minor stroke, one of the things that you always need to be very careful is when we have a patient with a minor stroke, sometimes a minor stroke, NI stroke score labeled less than 5 can also be because there is a large vessel occlusion, but the patient is having a lot of collaterals. But since we only go by a plain CT brain, so we don't know whether that patient has an underlying occlusion or has a high-grade stenosis, and still the collaterals are there, and hence the patient is scored less on NI stroke score. So this was one trial, like Tempo 1, where they confirmed minor stroke, NI stroke score of 5 and less with the CTA, proven occlusion, and they looked at the patients, and the patients went up the duration for up to 12 hours. And the TNK, they compared 0.1 with 0.25. Again, they found 0.25 to be better as compared to 0.1. Functional outcome better, and stroke progression and recurrence was better found in the TNK group as compared to the TPA group. At the end of the day, whenever a thrombolytic trial or thrombectomy trial is done, you want to see the recanalization effect on the clinical outcome. And in this one, they quoted that the recanalization, if you achieve a good recanalization in early time, you can have, the patients tend to have a better outcome. So, and not all minor stroke patients have a benign outcome, just because for the reason that I just told you before, that since we don't look at the vessel occlusion by doing, not doing CTAs or MRAs, so we just label them as minor strokes in the thinking that it might be a lacuna or something, and we decide on not giving the TPA or the tenecteplase. So what about TNK as a bridging therapy? So with the TNK, now since we only have a 10-second bolus, so the transfer time between the institutions, the transfer times from within the institution is far less now as compared to the one getting a TPA, and hence reduced door to puncture time as well. So in nutshell, better probability of having good recanalization in early times and hence good clinical outcomes. So 3 major trials looked at the bridging with endovascular, and I've named the 3 on the left side: the SWIFT direct trial, the Extend IA, and the Extend IA TNK Part 2. One was a thrombectomy alone, and the other, the patients did receive the thrombolytics. You can see the inclusion criteria. And again, the rates of reperfusion, earlier treatment, better outcomes, again, went in favor for TNK, but also the time matters came out from these trials also. At the nutshell, earlier the treatment starts, whether thrombolytics or thrombectomy, it does translate into a clinical effect. So 6 randomized controlled trials have been conducted since 2018, comparing IV thrombolysis before endovascular therapy and by a limited time window of 0 to 4.5 hours. So recently, a pooled analysis in the form of the Improving Reperfusion Strategies in Acute Ischemic Stroke Collaboration was published, and they looked at all of these 6 trials, and the combination of the IV thrombolysis and thrombectomy was found to be non-inferior, non-superior to endovascular alone compared to the combination. Benefit of bridging thrombolysis, time-dependent with earlier treatment associated with better outcome. Again, the common denominator is the time factor. So China recently published this bridge TNK therapy, because this is the only study that came out where the TNK was used primarily and everyone was subjected to it. I highlighted some of the things over here, especially when we are doing thrombolysis, how the patients are followed at time 0, 48 hours, 1 week and 3 months, something that we should also incorporate in our practice. And 3 months, it's mostly you must do a modified Rankin score, physical examinations, adverse events, and all of these things. So this is a very good way of following these patients if you're giving thrombolytics. If you look at the exclusion criteria, so they were very selective in the patient selection. They took out all those patients where there was extracranial tortuosity. If there was more than one vascular territory involved, they took those patients out. If there was any mass effect in the form of tumors, or even except for small hemangioma, they took the patients out. Any malformations, vascular malformations, they took the patient out. And any terminal disease with a low life expectancy, they took the patient out. So in the nutshell, they were very, very selective in the patient population. So they used expanded treatment in cerebral infarction score, which is a very good score because it divides the territories according to the reperfusion, 50%, 67%, or complete 100%. So what they found was that tenecteplase was, again, plus endovascular group achieved more functional outcomes compared to endovascular treatments alone, 53 versus 44, while the overall reperfusion with the endovascular was more than 90%, but it was, again, the evidence of recanalization before endovascular therapy in the tenecteplase group did make a difference. So some important points that came out. Lastly, what about the wake-up strokes? 3 trials have looked at the wake-up strokes, and so far there is no difference. So it's, again, the debate is out. This is a very important study, that the only one that just came out from Australia, because they are far ahead in mobile stroke units. And again, you can, from all the previous slides that I've showed you, I've told you again and again, one of the common denominators being mentioned is earlier treatment, the time. So if you can reduce the time by giving the tenecteplase when the patient is picked up from home and being brought to the hospital, you can improve the outcomes. And when these patients came to the hospital with the tenecteplase dose given, they found on a CT perfusion lower volume of infarct or the core as compared to the ones who got the TPA. So something that is going to probably change a lot of paradigm overall globally. Is this cost effective? US, China, Australia, they have, China actually only showed $82 difference in their difference between tenecteplase and TPA. So I wonder what are they doing differently as compared to the other countries. But overall, it is cost effective. So lastly, summing up everything, ease of administration, single bolus, no monitoring required, decreased chance of dosing errors, decreased wastage, and increased intracranial flow and outcomes. TNK is non-inferior superior in large vessel occlusion target mismatch. You saw the extend IA trials. Minor stroke, older patients, extend window. Again, more studies in the pipeline. Contraindications, no different than TPA. I would say that, you have to again be concerned about managing the hypertension. Any known intracranial condition, increased risk of bleeding and those type of things. So again, more or less the same as tenecteplase. So the ongoing investigations, these are the ones I would say that are important to look at, because they are looking at the endovascular therapy. They are looking at minor strokes with proven occlusions, being looked at posterior circulation, because you don't have enough literature, whether even on TPA about posterior circulations, adjunctive therapies, and also just intra-arterial tenecteplase as a mode of therapy as compared to endovascular thrombectomies. So it's interesting times to be coming ahead. So I'm going to end by just showing you a 2-minute video for the preparation, and then I can take questions.
How to reconstitute metallized 25 milligram powder for solution for injection. Metallized 25 milligram should be reconstituted immediately before administration. Prepare the following items: at least 5 milliliter sterile water for injection, a needle, and a 5 milliliter syringe. Please remind yourself to check whether the peel-off label has been transferred to the patient's file. Wearing gloves throughout the reconstitution process, remove the protective caps on the vials of metallized 25 milligram powder and sterile water. Assemble your syringe and needle. Swab the rubber stopper of each vial with an alcohol wipe. To avoid vacuum, fill the syringe with 5 milliliters of air, equivalent to the amount of sterile water you will take from the vial. Place the needle in the center of the rubber stopper on the vial with sterile water and insert into the vial. Inject air and draw 5 milliliters of water into the syringe. Dispose of excess air. Placing it in the center of the rubber stopper, insert the needle into the vial with metallized 25 milligram powder and fill the vial with the totality of 5 milliliters of sterile water. A vacuum in the vial will help draw the water from the syringe into the vial. Gently swirl the vial with the prepared metallized 25 milligram solution to dissolve any remaining powder. Do not shake, as this will produce foam. If the solution contains air bubbles or foam, allow it to rest until they disappear. The reconstituted solution for injection results in a colorless to pale yellow clear solution. Only clear solution without particles should be used. Carefully turn the vial upside down, ensuring that the syringe remains attached and is positioned below the vial. Draw up the appropriate volume of metallized reconstituted solution into the syringe according to this table. The solution is now ready for intravenous bolus injection and should be given over 5 to 10 seconds. A pre-existing intravenous line may be used for administration of Metallize. Ensure the injection solution is used as provided without adding any other medicinal products. Avoid using lines containing glucose, which is incompatible with Metallize. Flush the line after injection for a proper delivery. Please dispose materials according to your local procedures to avoid hazard risks. Any unused reconstituted solution should be discarded.
Thank you.
Thank you, sir, for a very nice talk. We have time for questions.
Ji.
Wondering how much experience do you have this tenecteplase in Pakistan?
Gee, I don't have in Pakistan, but I have been using it in US for 2 years because I go and do a little bit of work there. But in Pakistan, Punjab में we gave 5 injections to the Dr. Mohsin का है और तो हमारे जो PSM center उन पे है.
I would request you to give me the permission and this video to post on the various platforms, especially the NeuroNexus Academy, because this is very informative for the postgraduates to. Okay, thank you so much.
Thank you. I don't see any downside. The only downside is that the price is the same, slightly more expensive maybe, a little bit more. But otherwise, like, So Pakistan now is the second country in the region after UAE. So, but others are changing. They're in the process. But TPA is probably going to get indication for acute coronary in a couple of months.
Thank you, sir.
Thank you, Ji.
Thank you. The last talk for this session is by Dr. Malik Muhammad Adil. He is founder and CEO of Neurospace and pioneer in telestroke and teleneurology programs, and he will be talking about developing teleneurology in northern Pakistan.
Assalamu alaikum ji. Bismillahirrahmanirrahim. Everyone can hear me? Great. अच्छा जी, सबसे पहले तो खाने के बाद प्रेजेंट करना है, उसके बाद डॉक्टर कासिम बशीर की प्रेजेंटेशन के बाद बार्स वैसे ही बहुत हाई हो गए हैं. Let's try if I can do some better job. So just a quick introduction. I'm Dr. Adil, graduate of Shifa College of Medicine 2005. Did my neurology residency from Marshall Clinic Foundation, USA, and did my stroke fellowship from NIH, vascular neurology from NIH, USA. उसके बाद NIH में और हॉपकिंस में 4 साल काम किया, और थोड़ा सा जॉइंट कमीशन के साथ भी आई एम द जॉइंट कमीशन रिव्यूअर फॉर स्ट्रोक प्रोग्राम्स इन US. 2 साल पहले पाकिस्तान वापस आए, शिफा इंटरनेशनल हॉस्पिटल ज्वाइन किया 1 साल के लिए. लेफ्ट शिफा इंटरनेशनल हॉस्पिटल फॉर अ गुड रीज़न. कोई प्रॉब्लम नहीं थी, बहुत अच्छा जा रहा था. जस्ट वांटेड टू मेक श्योर. स्टार्टेड अ इंस्टीट्यूशन. ये नेक्स्ट स्लाइड कहाँ से होगी? ये नेक्स्ट कहाँ से होगी स्लाइड? इस पे से तो नहीं हो रही, क्या कहते हैं? लेट्स सी. ये वाला इतना नहीं हो रही जैम है. अच्छा, ये वाला ठीक है जी. So established this institution, Neurospace, the Asian Brain and Spine Institute, in April 2025. 5-6 महीने हो गए हैं इसको स्टार्ट किए हुए. The most important thing is कि Neurospace के majority share goes to a foundation जो कि मेरे पेरेंट्स के नाम पे है, फहमीदा सिद्दीक मेमोरियल फाउंडेशन, जो कि 10 साल से काम कर रही है, और उसको हमने अभी uplift किया है. The idea behind Fahmida Siddiq Memorial Foundation is to provide the telehealth and neurology, tele-stroke, and every single speciality in the remote areas where there are जहाँ पे physicians की कमी है और remote areas में. Moving forward, I think this is the only slide that is the most important in my presentation, and I think this is the only slide can convince you that how important the telehealth is, how important the tele-stroke program is. Global Health Security Index report कर रहा है कि पाकिस्तान में जो healthcare access है, that is around 52%, which means around 50% लोगों के पास healthcare access है ही नहीं, और जो बाकी 50% लोगों के पास healthcare access है, I think I don't have to explain कि उसके क्या हालात हैं और उसमें कितनी improvement की गुंजाइश है. This is the healthcare human resources in Pakistan. Physician जो है, there is a one physician for 1,000 patients. There is less number of nurses than the doctors. तकरीबन 0.5-0.4 nurses हैं for one doctor. Number of beds भी बहुत कम है. So the situation is pretty concerning. Now, because I'm talking about stroke, so looking at the stroke burden, unfortunately, we do not have a single multi-center epidemiological study that can give us the true incidence of a stroke, or that can give us a true prevalence of a stroke, or any other further data. But whatever the studies that we have, उसके लिहाज से the annual incidence is 250 per 100,000, and the stroke mortality is 28%, and the disability because of hemorrhagic stroke is 21%, again pretty high. Number of neurologists, Pakistan versus global, 1 neurologist for 1 million. थोड़ा सा डाटा अभी इम्प्रूव हुआ है, so they're saying it's 1.7 million per million is 1.7. Again, number of neurology residency programs, mashallah, Pakistan में start हुए हैं, so the situation is getting better, alhamdulillah. Stroke neurologists, no reliable data. I'm just aware of a couple of vascular neurology fellowships. एक शिफा में है, एक AKU में है, कुछ और institutions में होगी. But there are very handful of vascular neurology programs in the country. Current stroke care facilities, I know that a lot of people will disagree here. I mean, we have maybe 20, 25 stroke units, maybe
the TPA utilization, we don't know what is the TPA utilization. At one point, the TPA utilization in US in 2003 was like just 5%. That is now increased to 10%. Even America जैसे मुल्क में TPA utilization बहुत कम है. So I did not find a paper that can convince me and can tell me the true utilization of a TPA. And thrombectomy centers भी बड़े handful हैं. शिफा कर रहा है, Dr. Kashim Bashir माशाल्लाह कर रहे हैं, and there are a couple of other institutions. Because I work with the Joint Commission, I am the reviewer for the Joint Commission. There are almost 68 US programs जो मैं either या मेरे हाथ से certify हुए हैं या recertify. Actually, the definition is very different. When we start giving TPA in a hospital, we start saying, oh, this is a comprehensive stroke center. That's not the case. There is a set criteria that you have to do a certain number of cases to become a comprehensive stroke center. You need to have a certain backups to become a comprehensive stroke center, or even a stroke ready, or even a primary stroke center. So I'm not aware exactly what the data is on this, but there are a few papers that tells like there are 20 stroke centers, there are 80 CT scans, there are like 45 MRI in the country. Acha ji, so I think previous slides, it's pretty obvious that we don't have enough physicians. It's mera khayal hai ki it's a very, very open and a shut case. The thing is writing on the wall. I don't have to convince anyone here that the only way we can provide the healthcare access, regardless not in the stroke, any field of the medicine in Pakistan is telehealth. It's telestroke, teleneurology, telecardiology, telenephrology, everything. And we have to build a network that can serve the population. Otherwise, I don't think, I belong to a very small village in Kalar Kahar. The situation is pretty bad. अब हमने वहाँ पे एक telehealth का program शुरू किया है, and I'll talk about this in a couple of more slides. अच्छा जी, telestroke के models, there are a number of models जो कि अमेरिका में publish हो चुके हैं. Hub and spoke model है, different third party distribution model है, horizontal hubless model है. मेरा ख्याल है any model that suits your institution, you can pick up that model. I think the best model for Pakistan will be a hub and spoke model, क्योंकि हमारे पास बड़े hospitals जो कि comprehensive stroke centers हैं, या शिफा हो सकता है, या कोई आगा खान है, या ज़ियाउद्दीन है, या कोई और hospitals हैं, that can serve as a hub. And then they have to define the catchment areas, and then they can have a small stroke ready centers where they can utilize the resources and push TNK and transfer a patient for the high level of care, which is very much possible. Even in US nowadays, small territories in Alabama, in Mississippi, where still the healthcare access is pretty low and the situation is pretty bad, that's what they do for stroke. Telestroke advantages, I think there are a number of advantages, but I am just convinced there is a one advantage which make me convinced kiya कि I should go back to Pakistan and do something, is a healthcare access. If you can just improve the healthcare access, I think that is the single important advantage that is enough to convince me. Uske alawa, there are a number of things cost effective. One stroke neurologist can serve 5 or 6 or 10 hospitals. Like I used to cover US यहाँ से बैठ के stroke की call, and I was able to cover like 6 or 7 hospitals easily, and which is the need of the hour. This is the AHA and ASA guidelines. There is no question about it. Even a telephonic conversation, even a telestroke video platform conferencing, there is a level 1 evidence, there is a class 1 evidence. It's pretty straightforward that the outcome is safe. If you push TNK or TPA through telestroke by a video conferencing or a telephonic conversation, considering you have a great program set up, कि वहाँ पर जो nurses हैं और जो लोग हैं, they know what they're doing, you can have a same outcome. So the guidelines are there, pretty significant evidence. Now the outcome for the telestroke, again, I can list like hundred of publications that reported that if you give a TNK or make a thrombectomy decision, the in-hospital mortality, the functional outcome, the length of stay, everything is comparable when you make these decisions while in the hospital. This is the neurospace model. So we created a neurospace in Gulbarg, Islamabad. We have 3 neurologists, 2 US trained, 1 from Pakistan. We're welcoming more. And we're planning to build a program where we don't want to build a hospital. Pakistan में बहुत hospitals हैं, Islamabad में गिनती में नहीं आ रहे, समझ नहीं आ रही कितने अस्पताल हैं. So our program is to empower those hospitals, so that any hospital who is interested in becoming a stroke ready program or interested in becoming a primary stroke center. I work with the Joint Commission, I know the accreditation process, I know what is needed. We can build a program for you. Our team can help you, and we have built few things that I'm going to show right now. So right now, we have 3 collaborators. One is a general medicine hospital in Blue Area, state-of-the-art 25-bed hospital just established. The other is a Jhelum Cardiac Center, and the other is Chaksadat Cardiac Center. Pretty much the things are ready. We're going to implement a stroke program here, and hopefully, inshallah, within a month, this will be a stroke center. And then a lot more to come, inshallah. Now, these are the video platforms that are very expensive in US. Teledoc, probably Dr. Qasim Bashir ne bahut sare use kiye honge, maine bhi isme use kiya, but they are very, very expensive. We can't afford. Itne paise nahi hai hamare paas. So Neurospace has built a platform. Me and Dr. Vakar and my team, we left the job. हम घर में बैठ के हम लोगों ने developer को hire किया, and we literally day night काम करने के बाद we have developed this platform जिसका एक patient portal है और एक physician portal है. A patient can contact you through a web base, अपने messages भेज सकता है, and you can answer, which is all HIPAA compliant, no WhatsApp, no Facebook, nothing. And then there is a schedule. You can schedule your patients on your own, delete, reschedule. And then there is a video platform. You can just click which center you want to call. You can click Jhelum Cardiac Center, you can click GP Hospital, and then you can have a video conversation on the iPad in that hospital. This is pretty much up and ready, and this is the demonstration that we tested in a couple of hospitals. This is the Neurospace EMR. We have already, alhamdulillah, built independent EMR, जिसमें inpatient का जो outpatient EMR है, it's completed. You write all your notes in the EMR. There is a slicer dicer feature that you can import all the data and you can do a research. There is a messaging system. There is a lot of things that you can do in this EMR. Again, this is HIPAA compliant. You can have this access from your Android. You can have access from your iPhone. You can look at the chart while on the go. You can look at the message अगर कोई patient ने किया, and if you want to document anything, you can write document through your phone. A small documentation can be done through this app. Neurospace, again, bridging stroke programs for you, building stroke programs for you. All we need, मेरा ख्याल है Dr. Qasim Bashir इसके ऊपर काफ़ी डिटेल में बात कर चुके हैं multiple times, and he's doing a wonderful job in Punjab. That any hospital that has a neurologist or a ED provider or a telestroke cart and a CT scanner and a nurse with the basic training and a neurosurgery backup or a collaboration where you can transfer a patient if agar koi bleed ho jati hai, you can build a stroke center. And believe me, this is coming from a person who's actively working with the Joint Commission Chicago. I'm the active reviewer of the Joint Commission. Still, I go and review a couple of programs. Last year, मैं गया था. Next February, March, I'm going and I'm reviewing 2 programs. That's all you need. The key is a best trained nurse. The key is the best trained ER doctor. They need to know what they're doing. आपके protocols हों. They should have a good video platform. They should have a secure EMR where they can document.
and then of course a phone call and a video call and discuss a case and make a decision. The biggest challenge right now is a PACS system. We're working on it. It's very expensive. We're trying to see how can we secure a funding. We want to build a PACS system. So we talked to Dr. Rizwan Opal and Rehan Opal in IDC. Dr. Arsalan was very humble to connect us with them. IDC की lab almost fetch हो चुकी है हमारे EMR के साथ. When we send any investigation, that report, we can see report within 24 hours, 6-7 hours, जैसे complete होती है. Neurospace के EMR में you can download a PDF. And you can literally review an image in Neurospace EMR via IDC PACS system. We're trying to improve this कि जी इसको हम remotely कैसे, because one of the challenging situation is कि अगर हमारा resident imaging को review कर रहा है या कुछ चीज़ें हैं तो sometime a challenging case, a small subdural or epidural can cause a big mess. So we want our physicians to review the images at home कि कोई ना कोई supervision training के level पे कोई ना कोई supervision होनी चाहिए. Hopefully that will be coming soon, and this is the work that we put in last 4 to 6 months. And then of course together we turned hospitals into a stroke center. Last thing, as I said, हमारे पास enough neurologist नहीं हैं, हमारे पास vascular neurologist नहीं हैं. We need to collaborate. We need to come up with a national consortium जिसमें सब ने on call होना है. If there are 400 neurologists और एक दिन अगर एक neurologist ने on call होना है तो उसकी साल में एक दफ़ा बारी आनी है. या अगर 2-3 महीने के बाद या महीने में एक दफ़ा भी आप stroke call पे हों, you can cover the entire country. Believe me. So when I was in US, we developed a VA stroke program. I was the board member. Problem ये था कि VA के जो hospitals है वहाँ पे पैसे तो उनके पास बहुत होते थे लेकिन system is very much government oriented kind of thing. तो उसके लिए हमें program build करना था. Vascular neurologists थे नहीं, उनके पास अपने neurologists नहीं थे. They're very laid back. They don't want to come at night. They don't want to make a decision for TPA. तो हमने क्या किया कि एक consortium बनाया. And then we send invitation to every single vascular neurologist and neurologist कि who wants to contribute. तो हमने 2 hours की shift बनाई, 6 hour की shift and a 12 hour and a 20 hour. And everyone go in और अपना वो schedule कर देते थे, we are available, we are available, we are available. And believe me, in less than 1 year, we were able to develop a VA stroke program जिसके अंदर 167 hospitals थे और एक भी उनका vascular neurologist नहीं था. We used to pay them on call per hourly या जो भी था उनको pay करते थे, but इतना बड़ा program in every single VA hospital में stroke program था जिसमें TPA भी लगता था और thrombectomy के लिए transfer भी होते थे. But that was a national collaboration. They worked together. So teamwork is the only thing that we can develop different stroke programs. And this goes for every single subspecialty, not only for the stroke. This goes for a general neurology, this goes for cardiology, this goes for nephrology, every single subspecialty. बहुत ही important और challenging. I mean, I can't sleep when I think about the documentation, especially the privacy policy. Unfortunately, पाकिस्तान में कोई law नहीं है कि अगर आपने telecommunication या video conferencing के through patient देखा है, and if something goes wrong, what's going to happen? So I tried to look up the PTA की जो policy है, उसमें कुछ थोड़ा बहुत उन्होंने tele से related बात की भी है, but that's not enough. So we are in the process of writing the guidelines from Pakistani perspective कि हमारे challenges क्या हैं, and trying to put like government के साथ कुछ ना कुछ बात करना चाहते हैं कि this is the thing that we need to work on. इसको legitimate करें, कोई billing का process हो. Right now किसी से भी आप पूछें कहते हैं मैं तो telemedicine कर रहा हूँ, मैं तो telestroke कर रहा हूँ. भाई कैसे कर रहे हैं? WhatsApp से हो रही है, Facebook से patient देख रहे हैं, Viber से patient देख रहे हैं. Everyone is doing a telestroke. That is not a telehealth. It's not a safe practice. It is not a safe practice. And when I see a patient in Pakistan on tele, I'm scared So we're trying to see कि what we can do, कैसे बात हो सकती है, कैसे इसकी policy लिखी जा सकती है, but we're actively working on it. This is the case. I have 100 of
Dr.
cases.
Adil, sorry.
So done. Done. So I have a number of cases. Believe me, अब तक तकरीबन कुछ 70 केस मैं जमा कर चुका हूँ, जिसके अंदर प्रॉब्लम ये नहीं थी कि हमारे पास TPA नहीं था, जिसमें हमारे पास प्रॉब्लम ये नहीं थी कि हमारे पास स्ट्रोक सेंटर नहीं था. I can give you 70 cases. प्रॉब्लम ये थी कि जिस हॉस्पिटल में गए उस डॉक्टर को और ER प्रोवाइडर को ये पता नहीं था कि किस किस हॉस्पिटल में TPA अवेलेबल है. दिस इज़ द परफेक्ट केस. जो एक हॉस्पिटल में जाता है, स्ट्रोक लाइक सिम्टम्स होते हैं, वो CT कर लेते हैं, CT नेगेटिव होता है, दे सेंड इट टू द अनदर हॉस्पिटल, वो CT हेड एंड नेक कर लेते हैं, और फिर वो घूमता घूमता जब तक वो मेरी क्लिनिक में आता है 4.5 आवर निकल चुके होते हैं, TPA नहीं होता है ना स्ट्रोक. देयर इज नंबर ऑफ केसेस. तो जहाँ पेशेंट की अवेयरनेस की ज़रूरत है, वहाँ पर हमें अपने प्रोवाइडर्स को, नॉन न्यूरोलॉजिकल प्रोवाइडर्स को जो हैं, उनको बताने की ज़रूरत है कि अगर कोई पेशेंट स्ट्रोक लाइक सिम्टम्स के साथ आ रहा है तो उसको कहाँ भेजना है आपने, ताकि टाइम सेव हो सके. वी आर मेकिंग अ हेल अमाउंट ऑफ वीडियोज़ न्यूरोस्पेस के प्लेटफॉर्म से. काम ज़्यादा है, लोग कम है, पैसे कम है, बट यूल सी अ लॉट ऑफ वर्क दैट वी आर स्टार्टिंग इन इस्लामाबाद, ट्विन सिटी, एंड देन इन चकवाल, एंड देन मूविंग फॉरवर्ड इंशाल्लाह. Just collaborate with Neurospace, and thank you so much. Any questions?
Thank you, Dr. Adil. Yeah, sure.
Thank you, Dr. Adil. That's a very impressive and impactful work right here. You rightly pointed out that a very important part is training, having a nurse train and ER physicians train. In all of this, how do you think we can achieve that?
Yeah. So I think it's very easy. When I visited GLM Cardiac Center, they're doing a cardiac cath. They're doing a procedure for every single for cardiology. Then I visited Chak Shahzad. Then I visited general practice, number of other hospitals, even the trauma center in Kalar Kahar in my village. The nurses are great. I think we're developing a program to train a nurse, and that will be a 3-day program, and all you have to give us is 4 to 5 hours. That's it. देखिए, stroke की care में जो nursing care है वो बहुत important है, but it's not a rocket science. All you have to do, any ICU care, blood pressure और vitals आपने बहुत vigorously लेने हैं, every 15 minutes पे लेने हैं, 30 minutes पे लेने हैं, and you need to know कि जब क्या होगा तो क्या करना आएगा. And we can train our nurses. बाकी जहाँ जहाँ TPA लग रहा है वहाँ पर भी nurses कर रही हैं. So I think it's all about the education. We just have to empower. जब वो nurses को पता है कि there is Dr. Adil or someone else who we can call if there is an issue, and we can empower. I think this is just the education. This is just to collaborate.
Adil, I am Bashir Samra.
So
I have been following your Neurospace on various pages, and it's a very good start to have a telemedicine. My question is, how will you expand from Twin City to the other cities? Like Karachi has a lot of population and lot of district distribution, and on one end I am covering the North Nazimabad and the periphery, which is a very big catchment area, and on the other end I am covering the Clifton and defense areas. So
Sir,
my practice has a north and south is tarah se.
Sir, excellent question. Yeah.
How will you collaborate with this? Because we have a radiologist on call, we have biplane machines, and every time neurologists and my team in neurology who are training, they are giving the TPAs and everything, and mechanical thrombectomies they are doing. So I would request you to Neurospace should expand beyond the borders. So that will help us in catching the proper patients and proper management. Thank you.
Sir, excellent question. Thank you so much. Let me quick review on this. So the Fahmida Siddiq Memorial Trust, जो हमने अब इसको foundation में convert किया, already providing 550 households free telehealth in my village. for all the bread and butter, right? The reason why I came to Pakistan, the reason we established a neurospace, the reason we established a foundation, almost more than 50% funds, neurospace is a commercial funds foundation ko jaate. The plan of building this video platform and EMR before doing anything, this is the first check jo humne apne developer ko likha. First hiring in neurospace was our developer, because I believe in documentation, I believe in a video conferencing जो कि HIPAA compliant होनी चाहिए. एक दफ़ा ये हम बन जाता है, sir, we can expand all over the Pakistan, not an issue. आपके सेंटर में अगर ये चीज़ें मौजूद हैं, we're building a program, हम आपके पास आएंगे, 2 दिन spend करेंगे, teach, and then move forward. We're not asking for any qualification कि हमें कोई assistant professor का वो दे दें. We're not asking for any directorship. We're not asking for anything. Even we want to collaborate with the government as well, right? But we just wanted to show that we have this skill and we can build this program. So the plan is to go beyond the Twin City, but because I am living in Twin City, तो यहाँ कहीं ना कहीं से तो start करना है, but it will inshallah not limit to Twin City. We will collaborate outside.
I have an app in my Android. Whenever patient is admitted, I put EMR number and I see radiology, everything on my.
Beautiful.
So
that's all we need. That's all we need.
Thank you.
That's all we need. Thank you, sir.
Dr. Inam Khuda.
Well, thank you very much for a very informative presentation. I think telehealth is a need of the day, and especially in stroke and neurology. My belief is that if you really want to have good outcomes of your stroke therapy, even for hyperacute stroke therapy, you need to have a very good rehab team as well. Do you also provide rehab services?
100%. In Gulbarg Neurospace, we have a full-fledged rehab department. We have collaborated with different rehab जो instruments वगैरह provide करते हैं. If you want to visit, please come. We have 4 physical therapists. We have 2 speech therapists. We have 1 occupational therapist. We have started an ABCD program, which is an autism, ADHD, child behavior and developmental program. My son was on the spectrum of autism, so I get a chance to work with the Kennedy Krieger, which is the Center for Autism. हमने एक हफ्ता पहले ABCD clinic अपनी start की है. So we're working on autism as well. We have 2 psychotherapists, UK trained. They started their practice. We're looking into a neurosurgeon. We interviewed 2 neurosurgeons. So it's the entire neurology spectrum. So rehab के बगैर तो stroke हो नहीं सकता. हमारा दूसरा rehabilitation center इंशाल्लाह जेलम में we're starting in next couple of months. So yes, without rehab it's impossible.
Thank you. I now invite Professor Dr. Babar Khan, Chair Organizing Committee for the 25th International Neurology Update, for his vote of thanks.
Thank you very much, sir. Ladies and gentlemen, Assalamu alaikum. It is an honor and privilege to deliver this vote of thanks on behalf of the organizing committee and the Pakistan Society of Neurology. First of all, I extend my heartfelt gratitude to all our speakers for their exceptional contributions. Your expertise has enriched our discussions on neurology immensely, especially with regards to neuromodulation, neuroimmunology, AI, genetics, and stroke management. The participation of pharmaceutical companies is a very, very important part of the organizational aspect of the conference. I thank Hilton Pharma, Roche, AGP, Searle, Genetics, Helix, Getz, Searle Pakistan, Genix, Farmivo, Adamji, and MAQ for your continued support. Great help by Mr. Zikria from Solvers in managing the event. Finally, my deep gratitude, heartfelt gratitude to all the consultants, all the delegates and attendees, as your participation has made this conference successful. We look forward to a scientific and wonderful program tomorrow by the Pakistan Headache Society, and this portion also has the endorsement from International Headache Society. So thank you very much, grateful, and welcome to the beautiful city, and inshallah we hope to see you sometime in the future, inshallah. Thank you very much.
I now hand over the mic to the organizer.
This brings the end to the last session for today. We would like to extend our thanks to Professor Mohammad Javed Hassan, Professor Bashir Sumro, Professor Qasim Bashir, and Dr. Malik Muhammad Adil. We would like to call upon stage Professor Dr. Mohsin Zahir, Professor of Neurology and HOD at PNIS, to present the shields. The first shield is to be presented to Professor Mohammad Javed Hassan.
Now I would like to call Professor Bashir Sumro.
Professor Qasim Bashir.
Dr. Malik Muhammad Adil.
Dr. Shoaib Luqman.
Dr. Sarah Khan. Professor Alim Ibrahim.
Sorry, Dr. Manzoor Lakhia. Dr. Adnan Khan. Can we please have Dr. Adnan give a shield to Professor Dr. Mohsin Zahir as well? Dr. Babar, the dice is awaiting.
my apologies for not recognizing the hosting team led by Dr. Waleed Shahzad and Dr. Adam and Dr. Alina. They did a marvelous job. Thank you very much. We will have a group photo, but the request is that the general body meeting of the Pakistan Society of Neurology and the affiliated societies will occur just now. The request would be for all non-neurologists or non-related people to please leave the hall for the meeting. Thank you very much. All the other respected neurologists to stay on. The meeting will start after tea. 10 minutes. Group photo.